Welcome, everybody. They were just firing off here. Have this set up as about a 3-hour meeting. Eva is sort of master of ceremonies here a bit in terms of organizing and exact agenda. The agenda's bounced around a little bit, but we're gonna talk today about several policy options for the incoming administration. We have a general approach here of we've had an active group focused on the topic of food is health of about 100 people who've been sort of very connected with what's going on with food is health, food is medicine, make America healthy again types things. And what we're trying to do is capture those in some TED Talk like talks and share them with people that we're now going into the administration, and also share that with investors who are thinking that they should want to invest in this space. I'm going to cover a few quick slides up front. Eva's going to make sure we stay on schedule. Everybody can ask questions. Each presentation is sort of designed to be about 15 minutes long with about 5 minutes of opportunity. We ask all the presenters to try to keep to that 15 minutes. We can't solve the entire world today. Use some opportunity to get some feedback from people. The feedback is important. We may very well run these again. We will. We're just trying to figure this out as we stumble around with all the energy coming in around the world on the area of food is health, make America healthy again. Any quick questions as we start off there? Eva, I've got about 10 minutes right here up front, or?
Yeah.
Yeah. So just a couple reminders. We operate a perspective that we as a fund operate around is that we spend 1.7 trillion on food in the US. We spend 1.9 trillion on the healthcare cost of poor nutrition. This number has been recalculated, in some cases being much higher. Sometimes it's calculated a little bit lower, but basically the 1.9 trillion in the healthcare costs of poor nutrition is both the direct healthcare costs, economic impact, loss of productivity, a combination of all those things. Goldman has suggested that if we cure obesity, it will improve GDP by 1%. It also makes people's lives better. So that's a twofer. Both improve the economy and also make everybody's life better. So that's about a $3.6 trillion space of opportunity in which we can rethink things to go around the food system and the healthcare system. We're also at a point in time where we really have some really tremendous macro forces. The healthcare cost is getting too high and getting to the point that we can't afford it. CKD alone for kidney dialysis is 1% of the federal budget. 1%. That 1% doesn't seem like a big number, but it is a big number when you really think about the impact of that. People are getting obesity is up around 40%, diabetes or pre-diabetic 45%. Overall, just overweight is 75%. Big problem. And people don't like it. People want to be healthy. From a food security standpoint, the population, while the population's declining in some places, it's growing elsewhere still. And there's a protein gap, and there's a lot of questions around what are we going to do with food? And food is becoming a strategic defense kind of issue. There's a lot of trends going on with Brazil aligning with China and different things like that that are affecting the economics of agriculture in the US. There's an overproduction of food. The US farmer who's in the commodity market is actually having declining profitability, and they're trying to start looking through and thinking, is there a better product that I should be using or making, or should I do alternate grains? Should I do regenerative? How do I differentiate myself against Brazil and others? And so the US farmer is thinking about what their future is at this moment. Healthcare is thinking about what's going on at this moment. And then the individuals who the population, our population a little older, they're starting to say, my grandchildren are great. I'd like to stick around longer. I should be thinking about longevity. The healthcare system's not getting it for me. Should I be thinking about some changes? So we're really at a very interesting point where there are a lot of sort of giant macro forces. And then while there's a transition and a perception in the transition of the administration around the area that maybe we're going to move away from dealing with environmental issues and maybe they're going to be less important, it still remains that the combination of both U.S. agricultural production, which is 10% of greenhouse, or overall agricultural production is 10% of greenhouse gases globally. It still represents an element of waste. And when you think through the food system and what kind of food are we going to produce and how are we going to make it affordable, if you want to make affordable food, you really sort of got to remove the waste in the food system. If you remove the waste in the food system, you affect greenhouse gases. If you make food more nutritionally dense, you don't need to produce as much food. And then also the practices and regenerative to make food nutritionally dense requires more carbon in the soil. So we're in a neat kind of space where it really doesn't matter what your policy, like I care about the climate or I don't. If you want to improve longevity, if you want to improve nutritional quality, you really are going to get all of the above. You get economic benefit, you get longevity benefit, and you get climate benefit. So in a sense, the planets are sort of getting aligned here in a way where it really doesn't matter what your particular policy issue is. You can align these things together at this point and really team up with other people that may have been on the other side of your equation now and actually work together in a moment in time to really sort of push things forward. You've also got a little bit of craziness going on in terms of the overall policy opportunities where we both have sort of different strange bedfellows coming together. You know, the mix of Kennedy and Trump and Musk is sort of an unpredictable component, but they all seem to be energized around innovation and shifting things forward. So we really are a very interesting moment in time. We have long articulated a concept of what we call System C. System A is Adam and Eve. Garden, beautiful garden, beautiful food, everything's wonderful. System and but it's not scalable. Adam and Eve didn't, the Garden of Eden didn't scale. But then we had System B, which was really over the last 70 years, in which we sort of said, look, we want to stop famine. We want to stop wars related to food and famine. And so we went through the Green Revolution and we went from 20 bushels of corn per acre up to 308, I saw recently off of a combine, bushels per acre. So we really pushed that, and we really in 2010 got to the point that we got net calorie across the board, enough calories to feed the entire world. And now people live to 60 and get diabetes because of that. So System C basically says, well, let's take the best of A and the best of B, and let's use our innovative minds and use what we understand about evolution and nature, and let's get this thing aligned so that we're delivering affordable, nutritious food, that it's because it's affordable, that's the way you change behavior. People, if it's cheaper and better, people buy it. Uh, if we have people eating better food with more nutritional quality, then they don't have to go into sick care. So we have less diabetes, less cancer, less heart disease, and we think that this can be designed to be less than $90 a week, which is sort of a target price point that meets most people's pocketbook. This overall thing started some time ago. I would sort of say that the sort of movement towards the food is health, make America healthy again in terms of what can we do in the food system really sort of started with vigor probably in 2010. With all things, they don't happen right away. We're not talking about a change that's going to happen overnight. It took us 70 years to get into this mess. It's going to maybe take us 20, 25 years to get out of it. But we are sort of approaching when we hit that exponential point. Sort of, what are Amazon books about? Why does somebody have a bookstore online? And oh my God, look, Amazon Web Services. So we're moving in that direction. I think it's going to accelerate over the next few years, and we need to get policy aligned. It is having a macro effect. We are seeing a downturn for the first time in obesity. These numbers are not actually GLP-1 related. They're really sort of related to shifts in behavior in part through the more recent shifts, maybe partially GLP-1, but it's also just shifts in the younger generation attitude around food and health and such. But the trend is down instead of up, which is happening the first time. And when it starts going down, all of a sudden healthcare is sitting there saying, wait a second, my sickest patients are no longer sick. Wait a second. They go on GLP-1. I used to make $30,000 a year by these six people. Now I'm making $10,000 a year from these sick people. I've got to change my business model. And so we've got some really sort of tectonic things going on in the background. From a policy landscape, we're hearing about Make America Healthy Again. We're actually openly talking about curing obesity. We understand the economics around regen and soil health. There are people who are in production in commodity ag with regen, reducing their cost of operations below conventional farming techniques. We just need to scale that. Healthcare is not really ready for this decline. Large hospitals don't really expect these costs to go down, but they are, and that's going to change, as I said, their business models. We're seeing that CPGs are seeing with high GLP-1 patients a reduction of 25% of overall food consumption, 45% reduction in ultra-processed food consumption. That change, if that scales, if the price of GLP-1s gets to 100 a month away from $1,500 a month and it's on its way to $100 a month, that's going to change their business, and the CPGs are going to be bouncing around trying to figure that out, and they're running about 1% profit margins now. The feds are ready to sort of reshape SNAP and Medicaid to sort of underwrite food as medicine. Aaron Martin's going to cover some of that. Nestle and Pepsi are starting to rethink their supply chains. They're going around ADM, and so there are lots of shifts going on. And then finally, we've seen new product lines like Fairlife. Fairlife is an example where through vertical integration, the dairy operations, dairy production, dairy processing, branding, all sort of realigned and developed a product in Fairlife that at maybe a little bit more expensive, but high attributes around health, high demand as a result of the quality of the product. We're starting to see an opportunity to look at every single SKU in a grocery store with a Fairlife kind of model and say, we can make broccolini better, we can make Cheetos better, we can make Oreo cookies better if we sort of think from a standpoint of nutritional density rather than, I'm not sure we can make Oreos better, but anyway, but the point remains that there's an opportunity to make those kinds of shifts. So today, we are starting a process of trying to build a framework around policy to help new people come in. My perspective, past administration changes, there's a whole bunch of lobbyists run in and scream and yell at policy people and tell them what they should do. What we're trying to do is build a sort of a body of short stories, talk kind of way of stories of here are the people who are really the experts in the area, the domain experts. Mr. So-and-so who's now at HHS or USDA, you may disagree with them, but if you want to talk to the person that has experience, that really understands what's going on, the people on this call are those people. And so get yourself connected with the people who actually understand the problem, have a discussion and resolve your disagreements, and let's get the friction out of the process to make America healthy again. So we did some of this about a month ago. We've accelerated it here with 8 more. We likely are going to reshape this yet some more. We've created a website, foodishealth.ai, to maybe pull all this together into an AI engine to sort of make it easy for people to access. But our main objective here is to help policymakers and investors, because we've got to bring investment into the space, better understand how to connect and get connected with the people who understand what's going on so we can remove the friction and accelerate. So today, engage with the people on the call, raise your concerns, raise your insights. If you've got other people you think that we should be highlighting, let us know after the call. Eva, you're in charge. Any questions on all that? Great. Thank you, everybody, for your time. Eva, you want me to stop sharing, probably?
Yeah. So just to let everybody know, we want this to be interactive as possible. We want this to be a conversation. So please feel free to talk amongst each other in the chat. Raise your hand if you'd like to speak out loud. And you can also use the Q&A box as well. It looks like we do have one question in the Q&A. Is IFPA part of this conversation?
Aaron, do you know if they are? Peripherally they are, and they should. I should have forgot to connect them, but we will make sure they're connected in the future. I'll talk to Kathy about that.
All right, great. So Aaron Martin is going to be speaking next. Go ahead, Aaron.
Thank you. Hi, everyone. I'm presenting on our food as medicine model, FreshRx. We can call it food as health today. This is Pastor Deborah Cooper, who graduated from our program, lowered her A1C by 3 points, and now is kind of our evangelist in our community. And she enrolls new people in the program, and we're very community led. And I think that's one of the really important points that needs to happen, is that these types of programs need to be community led. But just a little bit about me to start. My background's in long-term care. I'm a gerontologist. I worked in all levels of long-term care from when I was 15 years old till I was 25 years old. I saw people on 15 to 32 prescription drugs at a time. I started putting together that the natural processes of aging were not matching up with what was going on in the United States. I was able to study death and dying in Italy in 5 different cities, and I really started understanding that there were people in the world dying of something called old age on 0 prescription drugs. And then right after my master's program in gerontology at USC, I was really lucky to get connected with a great nonprofit called Kiss the Ground, and I took a soil advocacy course and studied the science of regenerative agriculture. And I really started connecting longevity from the soil up. And I think that's a really important part that kind of the food as medicine space is still very much missing, and that we're going to have to prioritize sourcing around what really is nutrient density, what is medicine. And here I am in this photo. I was alongside Carter presenting to and testifying before Congress under the Older Americans Act in May of this year. And that really sparked our conversations and meeting a lot of you on this call today. So really grateful. So I'm now the founder and director of FreshRx Oklahoma. I'm the president of the Tulsa Urban Ag Coalition, and I'm the co-lead of Oklahoma's Food as Medicine Policy Coalition. So just to give a little bit of a landscape of food as medicine and what food prescriptions are looking like currently, we'll talk a lot about how a lot of these are focused in food insecurity and really the Medicaid population, but really the question is, how do we scale this? And there's a lot more people that are sick. But this is a pyramid that is from the Tufts Food as Medicine Institute. And it really shows the top 3 layers are really what is being touted as food as medicine these days. So there's produce prescription, which is kind of what FreshRx is. It's whole fruits and vegetables being prescribed to somebody with a diet-related disease. There's medically tailored groceries, which would broaden that above fruits and vegetables to other types of products like eggs and dairy and meat potentially. And then there's medically tailored meals, which are nationally being used, particularly they're pre-made meals for people, and they get them for 90 days once they're being discharged from the hospital. It's one of the attempts to prevent readmissions in hospitals. And there was one funding pathway that's really being used a lot in the Medicaid space, which is under the 1115 waivers for Medicaid. CMS has already put out things that says if the state wants to apply to include food as medicine as an intervention for state Medicaid low-income folks, we will approve it. So this is a little old. There's about 15 states that have passed this or are pending. Hawaii did pass theirs, and it doesn't show on here, but Alaska did pass theirs as well. Hawaii included local food procurement as a requirement for their food as medicine programs. Alaska included indigenous healing foods as a part of those, as a part of their 1115 waiver. And then what you also don't see on here is Kentucky is using something called in lieu of services. So is Florida. This is happening not just on the coastal regions, not just in more blue states. It's happening in red states too. Kansas is doing a pilot with United Healthcare and with Attain Health, which is Emily Brown. So this is happening all over. The thirst is real. I did a tiny little presentation in Hoxie, Kansas, in the middle of nowhere, a town of 3,000 people, and the hospital was doing a food as medicine program and had data to show. So this is just one part of the puzzle, but I imagine, and if the Harvard lawyers can say hi at some point, I know Erica's on and who's given me some great briefings, but we kind of see all 1115 waivers for state Medicaid approving this in the next 5 years. But they're not the only ones doing this, and this isn't really the only population, so we'll get into that a little bit. But more about the program just real quick. This is a doctor in North Tulsa. So for a lot of people that don't know, I'm from Tulsa, Oklahoma, and we launched our program out of North Tulsa, which is predominantly a low-income Black neighborhood. People were very dispersed from Greenwood, which was Black Wall Street. We had the wealthiest Black community in the nation in the 1920s. We also had the most wealthiest people per capita, which was the Osage Nation in Oklahoma during that same period of time. So very interesting landscape there. But we have the highest amount of mortality rates from diabetes in this North Tulsa area. Didn't have a grocery store there for 14 years. And this doctor standing next to me, Dr. Kent Farish, came forward and said, my patients are compliant with their medications and they're compliant with their doctor's visits and they're getting worse. And it's the food. And I want to prescribe food. And I said, I can help with that. And at first they said, well, let's just get the food from Amazon or Walmart. And I said, well, I have this understanding about regenerative agriculture and local food and nutrient density, and I think we should source it all local. The community committee said, Erin, I don't know if you'll be able to do that. You probably won't be able to do it at scale, or you won't be able to do it year round. And we've been doing it for 3.5 years. We've scaled our farmers. We use all local regenerative farmers, and it's incredible. So we launched this program in 2021 with 52 patients. We've quadrupled in size and now get referrals from 22 primary care clinics. We've also expanded to serving the Muskogee Creek Nation. They're one of 5 nations in the nation that got an Indian Health Services pilot for produce prescription. So we're sourcing all their food regeneratively and hope to include more indigenous nutrient dense varieties. But we need to build up more indigenous farmers. That's another challenge that we're absolutely working on. So this is what I call the care team, and our team is even bigger now. But we've expanded. We have people that represent the community, that relate to the community, and that's really important. And we have people that walk the walk. So we have people like Keandra and Jalen who have individually lost 100 pounds by eating well. We have Deborah, who graduated the program, who lives and breathes this. And of course, I obviously walk the walk as well when it comes to health. And so that's really important, is that people actually administrating these or implementing these programs need to be relatable, empathetic, encouraging, empowering, and they need to walk the walk as well as talk the talk. So our goals were to reduce A1C by 1 to 2% in a year. That's what the Geisinger food pharmacy study has proven. With education and food, you can do that in a year. And there's a lot of healthcare cost savings associated with that number. And that's just from increasing consumption of fruits and vegetables and improving patients' knowledge, empowering them to self-heal or self-manage, I'd say, or self-reverse their chronic disease. And then we, on the back of this program, really created a regenerative ag local food system with the same dollars. So talk about hitting 2 birds with 1 stone. And that's what we really have this opportunity to do now. And so here's kind of how the model works. So we screen and enroll. They get a starter kit. They go to food distributions and go to classes. So they have requirements on education. They get nutrition and cooking demo classes, and they also get food every 2 weeks for an entire year. They can be re-enrolled in the program, and we do see continued success, like in the North Carolina pilots. They've seen continued success. So someone starting at like a 9 A1C going to starting at 11, going to a 9, and then second year dropping down to like a 6.6. So we see continued success with people in these programs. We also believe that the local food and the regenerative agriculture is creating a whole community, but we also believe, and we'd love to further prove, that it improves the compliance in these programs because the food tastes so much better. They never really had a vegetable with all the nutrients in it, and it tastes so good. And I don't think I ever had a vegetable either before. And so here's some of our health outcomes. We've served more people. This is a little less than a year old. And it says our largest weight loss is 116 pounds, is actually now 132 pounds. She fully reversed her type 2 diabetes. She went from a 13 to a 5.1 in 8 months and came off of all of her prescription drugs, and literally half of a person. And this is not just a unique outlier. We have, obviously, another person hasn't lost 132 pounds, but we've had people lose 30, 50, 70, 90 pounds in the program. And our largest A1C reduction has been from a 13.6 to a 5.4 in 6 months. And we've run about 80% of people who finish the program have some type of reduction at around a 2.2 point average reduction. And then we've considerably scaled local agriculture and invested in the community, and we've saved the state a ton of money. And the question always is, well, Aaron, don't you get some of that back so you can scale your program? And that's inevitably the goal there. We'll talk more, but Ellen will talk a lot about a payment transformation, so I'll touch on it a little. But one thing she said to me in DC once was that farmers are healthcare providers, and we really should be aligning them financially in this process. And a lot of us on the call know about regenerative agriculture, but this is a great study done with David Montgomery's book, What's Your Food Ate? And this is cabbage, and this really shows you that the potential of regenerative agriculture, you actually have to eat 8 oranges now to get what you could get in 1 orange like 50 years ago. We not only have the potential to restore that amount of nutrients, but we actually have the potential to increase that amount of nutrients and in a much shorter time than it took us to destroy it. So it's really exciting. So this touches on 1115 waivers is really what a lot of people are focused on, but it has a prerequisite for food insecurity. We really want to elevate the conversation talking about nutrition insecurity. And in a way, a lot of us and most of us are all nutrition insecure. And we're all, many people, as you'll see in a later slide, we're all metabolically unhealthy, a large, vast majority of us. And we really want to make sure that we're seeing and treating all of these people with all these different health related diseases and not just getting hyper focused on the 1115 waivers, although these are very important. This is a very important group of people. The healthcare cost savings are considerable, but we want to broaden that a little bit. And so we're trying to move away from fee for service in the country, and that's what we've been working on for years and years. But a lot of these food as medicine programs are still aligning with food as fee for service models and really the value-based care models, and fully aligning them financially and really realizing these healthcare cost savings is really key to be doing. And so 93% of us are metabolically, have some dysfunction. Dr. Nasha Winters would say less than 6% of us are actually metabolically healthy, and we can reverse disease. When we can do it really quick. We've had people with diabetes for a decade. In 11 weeks, they're having success. So what have we been doing with people this whole time? So again, financial alignment, value-based care, healthcare, and agriculture integration in this financial alignment. So I'll talk about that. So here's our value-based care model. We actually just like 3 weeks ago signed a contract with a health insurance payer for next year for a D-SNP plan, and it's a full value-based care contract, including a price per month per patient and bonus payments aligned and incentivized for lowering A1C and blood pressure for those with heart disease as well. And so this is really a model and a hub that can be localized, that can be replicated, but customized to the needs of the community. And this is really key to be making sure that we're financially aligning. And my plan is to provide dividends to those farmers that participate with these value-based payments, these bonus payments, so that we're fully making the circle here of really treating the farmers as this slide says, as pharmacists. And they should really be benefiting on the team producing these outcomes. So what I see when these food as medicine programs are really contracting as value-added benefits, and really just being paid for the food and a really fee for service type of model, the health insurance company is benefiting from all these healthcare cost savings. And I really see these programs that they're being used to produce these healthcare cost savings, and they should really be sharing in those healthcare cost savings so they can build capacity and scale, because they're the ones really producing this, and they deserve to be treated as such. And so that's how we're going to plan to scale in Oklahoma and hopefully in the Great Plains region. I'm also overseeing a potential pilot in Southern Illinois. I oversee one in the Mississippi Delta and one in the Netherlands that has based their program off of our program as well. And so this is really important. Obviously, the experts are here on this call, and Ellen will talk more about payment transformation. She really helped BP2 Health Her firm helped us execute this program. We really pushed hard with the insurance company, but they obviously are very aligned in an innovative way. And so we're really excited. It'll be small in 2025, but we hope to expand with them in 2026 and talk to more healthcare payers. So Medicare Advantage plans are doing this. Any Medicare Advantage plan can already be doing this. Commercial insurance, they can already be paying for these things, and they should be aligned and being seen as a healthcare delivery model, not just a value-added benefit to get people to enroll on a plan. This is a treatment plan, and that's what it should be seen as and treated as such. And it's applicable to, like we said, 96% of the population, and even healthy people need to be kept healthy. And so that's really important. So I created this food as medicine resource guide on my website, erinwmartin.com. You can download it for free. I'm also available for consultation and helping you design and implement programs all over the nation to help sick people, because people are dying right now. And let's scale it and let's do this. So I'll open it up for questions.
All right, if anybody wants to raise their hand, please feel free to do so, or you can drop questions in the Q&A. Looks like we have a comment here, Erin, and I know you touched on this briefly. It says, you can bring healthy food to people, but if they don't know how to prepare it, cook it, if there isn't that supportive aspect with community members, supporting community members and encouraging connections at the table and in the kitchen, all with the foundation of DEI, it will not be sustainable. Do you have any other
Yes.
on that?
Yes. You cannot just ship people food and expect them to know what to do with it. You do need to give them access to that food and remove that barrier, but you also need to provide very supportive education in group settings. We do a hybrid version, so we have in-person classes. They actually have to come to a class to get their food, and that's the incentive to do that. We have Zoom classes. We record all of them on our YouTube channel at FreshRx Oklahoma. Those can be utilized and viewed by anyone. They're free. And you're absolutely right. We're really excited about a rural pilot that we'll be launching out of Cole County in southern Oklahoma, in the middle of nowhere, working with the county hospital there. And all of the community health workers are actually going to be running and enrolling and managing and supporting people in this program. So I really truly believe that it's got to be community member to community member. I always tell people we have truly created community around this program, and that's another element that you could absolutely measure. And people just show up at my doorstep and say, how can I be a part of this mission? It is being involved in something that's so much larger than yourself. So it can happen, and you can change it right in your community, and you can do it right now.
Erin, there's a question. Is your organization a nonprofit or a for-profit organization?
It's kind of a hybrid of both. We have a nonprofit program and a fiscal agent. We also contract through a for-profit as well.
Right. We have a few more questions in the chat, but I will go ahead and let Steve Mantle talk. Steve, you should be able to unmute.
Hi, Steve Mantle with Innovate Ag. Love what you guys are doing, both on the iSelect and Aaron, what you're doing here. Been following this for a while. Question for you, really intriguing on the farmer transfer payments and kind of flowing that back. Could you talk a little bit more about how that works, how that scales, and what you see that looking like in the future?
Yeah, it's an idea that I want to do. I haven't really developed much of it, but I feel like it'd be a percentage of sales. And first we'd pay out the team from some of those bonus payments, and then do kind of a percentage of sales. So for example, if we got for the first year and we're only seeing 100 people or something, we have the potential to make $20,000 in payments, but it's just the idea that they could get a percentage of that and those dividends would go to them. So we have about 25 growers in our coalition, and then we have about 10 to 15 that actively are supplying that. That could absolutely scale, and the potential for those value-based payments would scale alongside those people that we can serve. And also depends on the contract that you have with the health payer. But my idea is that the farmers need to be included in those healthcare cost savings because they're producing that. So I kind of envision it being a percentage of sales of what they're supplying for the program, and that they would get a percentage of those bonus payments at the end of the year, or when those value-based payments are paid.
Can I weigh in, Erin? Do you mind?
Yes, please. Yeah, please, Ellen. Yeah, it's
So
Ellen's idea.
No, it wasn't my idea. We just made it happen. I will just weigh in that I think if you have a healthcare background or you look at healthcare as a reference point, there's a redistribution of savings. And so if you look at an accountable care organization in that model, right, the inherent piece is that the primary care physician is going to get a big portion of it, right? And then maybe you're giving it to specialists. I think what makes this model so powerful is that in the food model, the farmers are really the primary care physicians in that. And so I think when you look at the total amount that is brought into Fresh RX from an incentive basis based on the health outcomes, I think modeling after a similar primary care thought process of saying, okay, well, primary care really is delivered by the farmer in this model. And so we need to take a similar portion of that savings and redistribute it. I think that's key. And the beauty here is that Erin is a not-for-profit. And so she doesn't have this massive amount of overhead and capital and everything else, and can truly give back to who's delivering the actual pharmacy, you know, the pharmaceutical intervention.
And that keeps them scaling and feeling incentivized and valued. And I think all farmers, you know, they need a lot more respect and support than they've been given. So this just is like, even if it's small to start, is something that could potentially grow and say they're a part of this financial model as well as the healthcare delivery.
What we're starting to see when we're talking about policy, we're trying to talk about what we call test beds, which are ecosystems in which the economics and the capital and funds and everything is moving around, maybe are a little changed. We definitely, and you'll see this across the presentations today, when you deal with sort of like tier 3 cities, rural, where you've got agriculture, maybe one or two major employers, and one healthcare system, there's more opportunity there for them to work to realign the combination of how we get feed people, how we get source regenerative crops, how does that fit into healthcare, how does that fit into the instability of the local hospital system. That community as a whole all wants to get a better solution. And I think both Aaron and what we'll see from ARH, and I think even in terms of some of the presentation from Walt around like what are the economics and how do these things shift, that there's an opportunity policy wise to center on that area and really improve health and cost all at the same time.
And just to add to that, I really believe that this could resurrect rural economy that has been totally destroyed. And instead of recreating, which I think a lot of the food as medicine space is just going to recreate the problem that we had before, which is sucking money out of the community instead of building up the community. And so if you do it in this community-led way, in this financially aligned way to keep the money in the community and build up and scale those farmers, you can scale them really fast. They scaled Beyond Me very quickly. They have room to grow. They just need to be also procured in an equitable way so that, you know, 20,000 pounds of carrots doesn't come out of thin air. They need money up front to do that and to scale. And we have agricultural partners that help them scale with high tunnels. We work very closely with the Conservation Commission, NRCS, and the USDA to help them scale alongside us.
All right, we have time for one more quick question. Joe Sunderman, you had your hand up. Should be able to unmute. All right, we'll pass it on to Jim Howard.
Hey, can you guys hear me?
Yes.
Okay, great. Aaron, I love the work that you do. I want to reiterate one thing you said, then I have a question for you. Is the community engagement, which seems to be something that kind of is elusive. And I think that's such a big part of your model and success there. I have a farm that's just 2 counties below St. Louis, and life expectancy is about 13 years lower. And we see these chronic disease issues, in these rural areas, and the states that have the chronic disease issue, and they'll tend to have a higher rural population. My question to you on the scalability, which I know everybody asks you to some degree on that, how can you engage outside of the payer to pay the bills on these programs? Are there other avenues that are highly motivated beyond that payer? And I'll give you a couple examples, and perhaps this is already embedded in your planning, but primary care associations or the state hospital associations, which are extremely well funded at times and have technology embedded in that too. But maybe out of the box, like out of the box thinking of how to implement this at scale that is beyond the typical get payer coverage.
Yeah, I think those groups should absolutely be involved and can have a lot of influence. And we've talked to some. We are working with the Hospital Association of Oklahoma on that rural pilot. They're actually going to be the ones hiring and helping fund those community health workers. We're working with actually private investors. It's a pay for success model. So the state agrees to pay the investors back if we produce the health outcomes. And so I do think that those associations should be more involved, and we hope to help them. We hope to get them to help us put pressure on our healthcare authority to include food as medicine, at least in the 1115 waiver to start, which I think will really open things up for Oklahoma and help these community-based organizations scale to treat people not just on state Medicaid. So yes, I think absolutely you should get all the organizations involved. I think this is a whole new market for farmers, and all of this movement around regenerative ag and agricultural communities. They could really, these organizations, the Farm Bureau, Oklahoma Farm Bureau has made this a policy recommendation for next year. It's a new market for farmers, and there's a bill out of San Francisco called the Food as Medicine bill. It's a national act that actually has requirements about quality of sourcing, and that's something we really want to see happen. So I think, yeah, expand your horizons. You don't have to just, there's so many organizations that could rally around this. So absolutely.
Thank you so much, Erin. There's a lot more questions in the Q&A in the chat. So Erin, if you wouldn't mind popping in there and answering them. And then I would encourage everybody that's talking in the chat to click on the blue box above the chat and change your setting to everyone so that everyone in the group can be part of the conversation there. So with that, we're going to turn it over to Eric Smith.
All right. Pleasure to be here. Thank you so much, Carter and team, for making this happen. It's always an honor to be a part of these groups and these conversations. Erin, amazing. Keep up the great work. So amazing to see the progress and the traction. I've been quietly following Erin from afar so I could build some of the tools to unlock her vision. And I'm going to tell you about how that's all working today. So I am founder and CEO of a company called Audacious. We are a technology platform for unlocking nutrient density, the nutritional comparison and quality of food. I'm going to take you a little bit through the journey of where we've been and where we're going. But we've really started with this question of why is eating for health so hard? All of our information about food boils down to a nutritional facts panel. The NFP, as it's so called, does not provide a lot of information. And there's two things that happen with it. One, it's actually rarely measured. It's actually computed off databases. And two, it can be plus or minus 20% in terms of what's actually in your food. The reality is it's something like plus or minus 100% of many of the essential nutrients that are in your food. And we are seeing this problem across the board. The reality is that there's significant variability in the nutritional quality of whole foods. And we don't know what we're getting, and we're paying for things that we're not getting as well. So this problem compounds itself in many ways. So what you see on the left, this average nutritional facts panel, is pulled into decision-making everywhere across our food system. Public health decisions, school lunches, how we model diet-disease relationships, how we set policies around labels and claims, how we procure food, how we plan meals, how we plan for food as medicine to become what we hope it will be. All of this is driven off the basis of a single data point of what is milk, what is beef, what is a tomato, what is a carrot, what is a pepper. And we're seeing not only is that quality of that food going down dramatically, but we have very poor information about what is actually in it. So that is showing up in major ways. Nutrient deficiency is a huge problem. So what I like to say is we're consuming the wrong ratio of macros, and we're not consuming enough essential micros. So nutrient deficiencies are prevalent, and we're overeating because we rely on empty calories that lack vital nutrients that help to satiate us. All of this nutrient deficiency question results in major implications for our human health, be that our physiology, how our metabolism works, how our brain works, how we feel day in and day out, our ability to focus and do work, our reproductive health, you name it, our bodies are experiencing significant deficiencies of essential nutrients, in addition to rampant toxicity in the foods that we consume. So taking a step back, how did we get here? Carter does a great job of talking about this. Every time we pursue an outcome in agriculture, the sole basis of that outcome and the success of that outcome is judged on how much we grew, the volume of food that's produced. That was okay in that system B the system B for a while, but it has caused rampant problems, and we now have the tools and technology to fix it. So what we're seeing in some of the biggest problems, and I don't need to rehash this, but is a loss of farms, farm wealth, and diversity in the food that we eat and consume, and an ultimate race to the bottom based on caloric production. Our goal as a company is to add nutrition back into that equation, to show that we can make better decisions at the farm and throughout the food system by using different genetics, stewarding the health of the environment in which the food is produced through regenerative practices to improve soil health, and changing the management paradigm, all of the inputs that we consume and how we apply inputs to those systems will result in a system to produce more nutritious food. So we are focused on two key metrics, the amount of nutrition delivered per acre and the amount of nutrient density delivered per crop. And I will talk a little bit more about both of those things and what they mean. But the ultimate goal is for us to deliver nutrition, to get out of this mindset of producing calories. So I do like to take a step back. I think this is really critical, and this has been a big learning experience for us at Audacious. What is healthy food? Healthy food needs to be safe and nutritious. If there is a prevalence of harmful contaminants that are destroying our microbiome and our system, that nutrition does not matter coming into your system. So we see and are continuing to see an abundance of toxicity in our systems that is preventing the uptake of essential nutrients. We see this in our soils and we see this in our guts. So when we talk about healthy food, we talk about safe and nutritious. But nutritious also needs a major update to figure out how we communicate this information. Today, the federal government considers all whole foods to be nutritious. However, we've experienced rapid and significant declines in the nutritional quality of those foods and the toxicity embedded in those foods. We are seeing 30, 50, 60, 70, 100% plus declines in essential nutrients to human physiology in the whole foods that are being consumed and produced and consumed. So what the goal of Audacious is to unlock the ability to measure, compare, and report the nutritional quality in an affordable and transparent manner. What we hope to unlock is both an apples to apples comparison. How does this apple compare to that apple? How does this milk compare to that milk? How does this steak compare to that steak? And apples to oranges, so that we can also do better meal planning, better dietitians, better dietetic tools for helping to understand how much essential nutritious we're getting in our food. A little bit of background. This is the system that exists behind unlocking food quality measurement. It is a very fragmented lab system, similar to what many experience in the healthcare system, with handwritten analytical chemistry data, inconsistent methods, you name it. It is very difficult to produce this data and this information at scale. The only people who are able to actually actualize this information today are large food companies, which have teams of people, including food scientists, data scientists, nutritionists, marketing experts, regulatory, legal counsel, to take nutrition data and turn it into a marketable strategy for a food product. And that has all been on the basis of processed foods, which we also are starting to learn the story about. So this has been a huge barrier to all of us in the food system, especially producers, who cannot bear the cost of hundreds of thousands of dollars to bring a higher nutritional quality product to market. We're talking about tens of thousands of dollars in testing and hundreds of thousands of dollars in people cost to make nutrient density a reality for these producers. So we have built a technology platform that allows anyone in the food system to measure and compare the nutritional quality of their whole food products. We help people to understand, compare, position, and eventually improve the nutrient density of their foods. The ultimate goal of Audacious is to connect the dots between nutritional outcomes to link agriculture to human health. We want agriculture to be oriented around producing nutrition, not just calories. What does this look like? Today, we help people to see the nutritional composition of the foods that they are producing. We help them to benchmark and understand versus different practices how much nutrition they are delivering relative to other producers, relative to other farms. We help them see and understand how much nutrition they are delivering on a relative basis. And we put all of that in context of human health. Nutrition is also highly seasonal. It's important that we're able to capture that seasonality and begin to see and differentiate which farms are performing better than others and why. So before I continue with the last few slides here, just a quick tour of what we've built so far. We have built an incredible database that has surpassed the capabilities of what the USDA currently uses. We are incorporating hundreds of samples into our database to be able to show in real time the distribution of nutrition that is being delivered and experienced by anyone throughout the food system. This ultimately helps us to benchmark, and it helps us to move towards a better understanding of what nutrient density is and how much nutrition is actually being delivered and why. We are very much in the phase of, we've cataloged and understand about 250 individual nutrients. We are starting now to move into summary metrics, and eventually in 2025, we will release our NPS, which is a nutritional profiling system or a score that helps to benchmark and bring nutrient density into reality. Some of this you can see just visually and understand based on these bottom bars that there is significant variability. So the claim basis by the FDA results in a below 10%, good source of above 10%, and then a rich source above 20%. And for any single food type, you can see that there's extreme variability being delivered in the nutritional quality of these products. This is one of our first data sets, and we'll actually be releasing it publicly in the next few weeks to kind of catalyze these differences. We're also able to differentiate these things on the basis of currently on grain-fed and grass-fed practices for animal products. And we have many experiments underway to demonstrate the potential of healthier soils produced via the production of regenerative practices. Coming back. I mentioned analytical chemistry as the basis of our platform. We do work with labs, lab partners. We produce a lot of this data on the basis of analytical chemistry. But we are also doing this using spectral technology. So the basis of our innovation here is actually using physics instead of chemistry to predict nutritional composition. So we build reference chemical libraries off the backs of analytical chemistry. Then we use a spectral technology stack to actually look at the vibrations of molecules within those food samples, and then build reference models to basically predict what the actual food composition is. We hope this drives down the cost of testing by 1,000x. A complete nutritional profile today can cost thousands of dollars per sample. Our goal as a company is to bring that down into the tens of dollars per sample over the next few years, making nutrient density an actionable indicator and metric for producers across the globe. Just a few key points here that nutrition is relevant for everyone in the supply chain from beginning to end. We talk about genetics and breeders who work on producing. They're all focused on yield at this standpoint. There's very few innovation to focus on nutritional outcomes. We think that's a huge unlock. But producers, distributors, processors, CPGs, retailers, and consumers all have a role to play in sourcing and delivering nutrition. We are incredibly excited and working with many different stakeholders throughout this ecosystem to make nutrition the focal point. The last thing I'll say is processing plays a huge role here. Shipping, processing, storing. We don't know where we're starting and we don't know where we're ending. And local supply chains, geographic supply chains, regional supply chains, they're all unique. And so it's hard to make these generalizations about leafy greens being shipped from Salinas to Boston versus an indoor hydroponic in the Northeast shipping to Boston. But we now have the platform to begin to unlock those insights and understand who's delivering nutrition and why. I came at this from the climate side of the problem, and these things are intrinsically linked to one another. Carter, again, talked a lot about this. I don't have to reiterate this point, but our goal as a company is to connect the dots between healthier soils and more nutritious food, to Aaron's point. There is now systemic evidence in many papers that shows when you get your soil organic carbon and better biological cycling of nutrients within your soil, it becomes more available for the plant. Same thing that happens in our guts. When we have healthy guts, we're better able to uptake that nutrition. Same thing for the soils. Our soils are deplete and ridden with toxicity and chemicals, and those plants are not able to uptake the nutrition that they need to build nutrient-dense food. So there's not hard and fast rules here about regen equals nutrient density. There's many different regions, systems, crops, all with many different outcomes. But for us to unlock nutrient density as a solution, we can show that the abundance of relative health compounds within food can be much higher than it is today. And soils are going to be a very important driver of that, unlocking the storage of carbon in those soils across the globe, which means that these concepts that we're talking about today are both a climate solution, a nutrition solution, a health solution, and a market solution. A few closing points. I think these were some great questions. We have learned that food needs to be safe and nutritious. You can't have one without the other. Food quality is highly variable. We're not getting what we need nor what we think we pay for. What is working, what's not working? I think there's a lot of regulatory structure that needs to be unlocked here. There's huge barriers in this space, given how we talk about the commoditization of food and how we promote food commodities that are eroding the competitiveness of farmers and the ability to get more diversified crops into our food system. Diversity is key here. And if you look across the globe, we do not have enough fruits and vegetables in production in our systems to actually unlock food is health at scale. So vegetable, meat, protein, and fruit production is going to have to increase dramatically to actually shift the health game in this country. Why is it important? Carter iterated this, but mind, body, and spirit of the American people are really at stake here. It's the lowest it's ever been. Hyman talks a lot about this, and he's had a few good podcasts, but having nutritious food and having your mind be in balance and your mental state, being open to collaboration, compromise, and effective communication, I really think that the fragmentation of the political discourse in this country has a lot to do with the nutritional quality of the food. It's not a stretch. Productivity and resilience. This is a core economic issue. There's no doubt about that as we not show up to work, as we're not excited about work and we're not engaging, we're not building a resilient and productive American economy. What do we need to scale? Funding and partnerships. We are a for-profit. We closed around earlier this year. We'll be raising in another year and a half or so. We are a for-profit startup company that's looking to change how the system works. Partnerships are key to that. We are willing to work with just about anyone if it fits our mandate. So please reach out. And who are the smartest people on this topic? Please let me know when you find them. This is a new area. I've actually had trouble hiring for many key roles in my company because knowledge around the nutritional quality of food, its impact on human health, its impact on the land and regenerative agriculture. This is a new area. It's exciting, but yeah, please share the good word.
Thank you, Eric. We have Jessica Nad has her hand up. Oh, it went down. Oh, sorry. We have a couple questions in the chat. Do you have a list of papers you mentioned in your slides, particularly about decreasing nutrients and SOC correlation?
Yes, I can give them to Carter, and Carter can share them in the distributed resources.
Wonderful, thank you. And then Debbie Kennedy asked, Eric, are you familiar with the work at the Chef's Garden in Ohio? The late great farmer Bob Jones Sr., who Debbie had the privilege of interviewing, was the grandfather of nourishing, seasoning the land to grow delicious, nutrient-rich food. And she has a link there in the Q&A for anybody who wants to check that out.
I'll be sure to check it out.
Thank you. All right, so I think that there's more conversation going on in the chat, Eric, if you could take a look at that. And just a reminder to everyone, above the chat box where you type your message, it says two. If you click that blue box and hit everyone, then everyone can see your comments and can weigh in on that. There's a lot of good insights on our panelist side, but also on our attendees side. So you want to make sure everybody can see what you're saying. Oh, Dr. Joe, did you have a question? Go right ahead.
Thank you, I do. Oh, great presentation. I love what you're doing because as I've looked at the nutrient content of food over the last 100 years, it's dropped dramatically. So I was wondering, are you measuring such things such as fluorine, for example? Because that's one of the examples of a molecule that's lost from the food supply when foods are grown chemically rather than organically.
Yeah, so we break it out into three classes of compounds that we're looking at right now. One is like just the traditional NFP, how the USDA looks at it. The second is what we consider our expanded index, which is many micronutrients, including vitamins and minerals, including vitamins and their derivatives. And then we're looking at all the fatty acids, all the amino acids, not all the fatty acids, many of the fatty acids, and then some of glycomic structures as well. So it's pretty simplistic, but we're one step beyond where we need to be. But no, like the compound you mentioned, we are not currently measuring, and we have the ability to do one-off projects with people interested in certain compounds, but we've standardized a list of about 200 plus compounds that we're measuring, and we're seeing, yes, as you noted, significant.
Fantastic. So I wrote an editorial facetiously entitled Unimportant Molecules, and it's in PubMed. So if you want to get some suggestions on important molecules, take a look at the article.
Will do. The bioactive space, there's an organization called the Periodic Table of Food Initiative. There's Brightseed that are trying to work in this space of classifying the importance of what we traditionally consider secondary plant metabolites, bioactives, phytochemicals. There's a relationship between antioxidants and vitamins that are essential. The NIH and the USDA are not doing enough to investigate and understand the relationships of these compounds to human health, but it is absolutely clear that our current conventional production systems have eliminated many of these biochemicals from our food.
Thank you, Eric. Let's keep that conversation going in the chat and Q&A. And we are going to turn it over to Walt Duflock to speak next.
All right. Thanks, Ava. Let me share this screen out. You guys see that okay?
Yes.
Trailer and moving across country.
All right. So we will jump in. So morning, folks. Great conversation and congrats to those earlier. Aaron, fantastic. Eric, great work. This is totally energizing on a Friday. So I'm Walt Duflock. I'm with the Western Growers Association. I run the innovation team, and Carter asked me to come in and speak about some of the specialty crop automation and labor challenges and opportunities as it relates to this topic. So we'll try and roll through a deck that we rolled through a couple times already, including with a few folks on this call at Bonnie Dunes a couple weeks ago. I'm going to start with the ag labor problem, roll into the negative impacts of what ag labor is doing to some of the California farmers. Talk about two options from there, right? We either innovate our way out of this, or due to capital constraints, which we'll talk through in a bit, we see the acreage continue to move at an increasing rate of speed. And we'll talk about founders and builders that are leaving California real quick, because I think that has an impact on what you're able to get built and grown out here. And then we'll talk about two parts of policy considerations, one for ag, one for ag tech. And the ag part is summarized as this: if we lose the acreage, we lose the ag tech because it follows the acreage. So the headline on California ag labor, it's hard to find. It's getting more expensive. We've got a lot of data around that. UC Davis will tell us that 850,000 unique farm workers are hired every year in California. It equates to about 425,000 full-time equivalent farm workers just in California. And I did the math, and I'll work through this in a minute here. We spend in California alone $16.3 billion for 850 million hours of farm work every year. It's a blended cost of 19 an hour, and it's going up. What's driving it up? Huge lift in regulatory costs. This is Lynn Hamilton and Mike McCullough from Cal Poly. Went from 109 an acre per year for regulatory costs to 977 per acre per year from 2005 to 2017 for an acre of leafy greens in the Central Valley, in the San Joaquin Valley. The three main drivers were labor, minimum wage rates, breaks and overtime rules, healthcare, Obamacare, and then food safety. During that time, if you remember 2005 to 2017, right, we had the LGMA emerge and we had food safety modernization. So we had industry and government get involved on the food safety side. Right thing to do, but adds massive cost to the cost of being a farmer. On the hour count breakdown, somewhere between 60 and 75% of it is on harvest. Keep that in mind as we talk about what we're solving, what we're not. And the remainder has been on cultivation. So things like weeding, planting, spraying, not harvest, basically. And that, again, is Cal Poly data from last year on a project we work with them on. And the second big problem after the regulatory cost is the lack of domestic availability means increased H2A and costs, right? So H2A is the immigrant farm worker labor. There's been an 8x lift in that. From 2005, it was 48,000 up to the 2023 number was 378,000. Those are Labor Department stats. So massive lift in H2A. What that does is it pushes the blended rate a lot higher, right? So our California mix is 90% in-state and 10% H2A, and that's a 3x lift over 5 years for the H2A component. So the domestic sits at about 17.25 an hour. The H2A, on the other hand, has an AWAR, adverse effect wage rate, where we set the rate relative to market, state by state. Ours is high. I think we're the highest in the nation. Steve Mansell in Washington may be chasing us, but 1975 is our AWAR. And there's another couple costs on that. $7 to $9 an hour for housing, transportation, and food on H2A labor. And AWAR has been going up about 5 to 6% for California. This year, it looks like we were less. I think we're in the 1.5 to 2% range unexpectedly. So it didn't see a huge bump in California for the year going forward. And the other headline is every 10% lift in H2A pushes that average labor cost up by at least a dollar an hour as we look at the math. Last comment on labor and what's happening to the economics. PAGA, the Private Attorney General Act, which is currently unique to California. Those of you in other states should hope that that stays that way. It deputizes private attorneys to chase class actions for any workplace violation of any size and class action it, and it is an extortion racket, quite honestly. It's an average payment of about 1.1. It impacts, and I know of very few, I know of almost nobody who hasn't settled. It impacts construction, housing, events, anything where there's a lot of 1099s, it impacts. And the caseload is up about 1,440% since it launched in 2004. So if you're in California and you're farming, PAGA is hitting you hard. There's 5,000 cases alone in 2022, according to my Western Growers colleague, Jason Resnick. So that's all the stuff that's going on from the labor side, and that's making it a ton more expensive and a lot harder to find good labor and get them onto the farms. Here's the impact of that. We are losing massive amounts of acreage and farming. I rolled the numbers out. Everything to the left of the red bar is the USDA census numbers, the 5-year numbers. Actual data through 2022 from 1997 on, and projected data straight lined it. I did nothing to account for things like SGMA, unsustainable groundwater, or PAGA's impacts on further acreage move. I just said, based on what we saw the last 25 years, what do we forecast the next 30 years to look like? And you can see the numbers. We will lose 1/3 of our acreage over 55 years, 9 million acres lost in farm production. We'll lose 51% of our farms, down 45,000 in 55 years. And when people in Sacramento tell me, "Oh, is that a problem?" I say kindly, "Yes, it is." So this is again the straight line projection on what's happening to California ag. So there are two opportunities, right? Option one, we fix this with automation, right? So how are the robots doing? Not bad. We've got about a 200 million year in sales, it looks like. That's US market. We're putting the global number together this year. And it looks like we'll have somewhere between 700 to 800 million. And I'm almost ready to increase that based on the last couple of trade shows I've been at and some success from these folks to probably 800 to 900 million over 3 years. So we're not a $1 billion category. It takes us 3 years at least to get to a $1 billion category. So put a pin on that number. We're not that exciting to some of the venture capital firms, right? Because we're not that big a market as we'd like. But we're getting there. So where's the successful areas? Well, processed and frozen, we're good. If you put it in a bag of salad, if you put it in a freezer section, we're good, right? We've done all that. It's the fresh stuff that you present that we want presented to customers as whole food, where the hard part is. It's really hard to pick strawberries and apples. They're very delicate. They have to be placed in the bin just so. And so we're working hard on that. So where we're making progress, the weeding robots, the carbon robotics, laser weeder, the Stout mechanical weeder, the FarmWise mechanical weeder, there's 100 plus of those out in market. I would argue carbon robotics and Stout are the market leaders at this point. FarmWise chasing. Spraying, we've got Gus from California and now up and down the West Coast. Eco Robotics from Europe making their way to the US very successfully the last year. And Verdant, we've got 100 plus spraying robots out there. It's probably 200 plus by now. Harvest Assist, we've got the smaller robots. So spraying and weeding, those are like 240,000 up to about $1.4 million each. The Harvest Assist and the DIY platforms, 400 plus burrows and growing nicely, 150 plus Farm NG platforms growing nicely. Those are more 10 to 25,000 robots. So they're smaller robots in cost and smaller robots in footprint. But all of those are making progress and they've fundraised and they're out in traffic, pretty successful at this point and going forward. I think a decent chunk of those will get to cash flow and to a good outcome in the next 5 to 10 years. Where we're having limited success, and I won't walk through the details on this because they're not where we want them to be yet, but that 60 to 75% of ours, we have not been very successful at automating fresh fruit, nuts, and vegetables harvest, right? We can do nuts, but the fruit and vegetables are really far behind. So that's kind of where we're at. On the recent activity side, we have seen some progress. John Deere acquired Smart Apply and Bear Flag and did a joint venture with Gus, the spray company, in the last couple of years. That's all great progress. This is not a space where we'll see a lot of fancy IPOs. It is a space where we hope to see a lot of acquisition activity over the next couple of years. But when Deere and Bayer struggle on the automation and chemical fronts, right, it doesn't leave as much money for either strategic investment or acquisition activity. Case New Holland, excellent typo on my part. Sorry, there's a D on that. Raven and Stout are the two new areas. Raven was a $2.1 billion acquisition by Case New Holland. Stout was a nice joint venture kind of investment with intent to do more, if you will. So those are good to see those channel partnerships and those dollars flowing. Kubota did acquire Bloomfield Robotics. My buddy Mark DeSantis is the CEO over there. Good to see Kubota getting more engaged in California specialty crops. And Carbon Robotics, the laser weeder I mentioned, they've got both NVIDIA, hottest company in Silicon Valley where I live, by a mile right now, and Bond and ex-Sequoia, a real name brand venture capital firm, are now on their cap table and investors. Their last round was $70 million. That's very encouraging. Their total raise is up near 160 million. Also very encouraging. So we're hoping to see some good outcomes from this. So that's option one, right? That's the automation option. Let's tell you why that's getting harder before we go to option two. Venture investing was a really rough year last year, right? We had IPOs, initial public offerings. This is how limited partners that write checks to venture capitalists, that write checks to startups, the entire process starts when limited partners write the capital to get the process started and the funds underway and they make investments. Those IPOs get the cash back to everyone in the cycle, right? Those initial public offerings, they were down 85% in 2 years, over 1,000 in 2021. Just about 150 in 2023. Massive problem. That prevents the capital from making its way back into the system. Concurrently, you saw venture capital system-wide, not ag tech, drop from 345 down to 171 billion over 2 years. And again, a 50% drop, massive drop. So because of this lack of IPOs, LPs aren't writing checks. What happened was You've got a bunch of founders and VCs who got clever and came up with ways to not do IPOs, but get founders some money for their successful work to date, right? As a result, there are now more private unicorns, billion-dollar companies, than public unicorns in 2024. And as Carter and investors will tell you, that is a bad thing, right? You've got all these private companies, the cash isn't cycling through like it should be. Now, the only semi-bright spot in 2023 was artificial intelligence. You had 50 billion, 1/3 almost of capital coming into that space. That will generate some forward-looking returns and some stuff for vertical, but it'll take a while, right? So venture investing, really bad out in Silicon Valley, right? Massive drops in all numbers. And it's a systemic thing. How about ag tech, right? So we had a huge run from 2013. Climate Corp, Dave Friedberg's little company, got bought for $1 billion by Monsanto, now Bayer. And after that, venture capitalists and founders said, oh, that looks like an interesting space. I should go check it out. And they did, up to the tune of $53 billion in 2021. And then the ugly came, right? So then we had the 69% drop in funding you see from 21 to 23. Sorry, 70%. Looks a lot like Cortec, right? And the hardest hit segments. So what happened to ag tech specifically, right? The hardest hit segments were controlled environment agriculture and alternative proteins, right? They were 42% of that big blue bar, up to $53 billion. Both of those segments, as the specialty crop grower and as a fifth generation farmer, were way overhyped and way over their skis and turned into dumpster fires. And I'll walk you through the unit economics and how bad they were. And I'll walk you through the unit economics at the store and how bad they are. It's going to be tough for vertical farming to even make an impact against greenhouse, in my opinion, let alone competing with our guys who grow in the dirt, right? I think there's a lot of challenging areas about that space. I also think they now have to live with $7 billion of burnt capital and a lot of scars from investors. So a lot of the folks who were chasing Impossible Burger to beat up on livestock, and they were chasing vertical farms to beat up on conventional and organic dirt farmers, they now have a tough road to hoe because they burned through a lot of capital. And the venture capital tourists who were just driving by, they have left. And if I'm being honest, that 53 billion, a lot of it was blood money. We give it back and never put that number over 30 billion if we could, but we can't. So we live with those scars. So option 2, right? If we can't automate it, and if the capital's not there to continue to do automation as we would like, the ag acreage moves. And I took a look at some numbers to make the point clear, because I used to just say, if we don't automate, it's bad, and we can't pay for labor, and bad things happen. And everyone in Sacramento and DC will say, well, but so what, right? You guys are smart. Farmers will figure it out. You know what they're figuring out? It might make sense to move some of the acreage, not just to Arizona or to Mexico, which has been happening for a while, but further south to LATAM and Peru. So here's the numbers, right? So U.S. has outpaced ag exports compared to LATAM, which is everything below Mexico, since 2005. LATAM grew by about 100%, right? 52 to 108. And there's 17% of global ag exports if you look at the last 3 years. So they're a big and growing beast in the ag export category. U.S. grew from about 65 to 180, so a 175% increase. So relatively, U.S. growing faster. California was in the middle at about 141%. You can see that down there, 9 to 23 over 18 years. But look at Peru, right? This is the shining star in the whole hemisphere. 465 million to 10.6 billion, a 2,180% increase, right? And you can see down below from a friend of mine in Peru that we did the panel with at Bonnie Dunes that they've got new projected acres of 770,000 on top of 500,000 existing acres. So they're going to be at 1.3 in the specialty crop space very soon. Remember, we're losing acreage in California. You can see that Peru's on tap to add a whole lot more acreage. How are they doing that, right? Why is Peru ag exports growth outpacing California? Well, they're making great investments. They're making great policy decisions, right? They're building and have built and have opened, as of last week, a $3.6 billion port, the one on the right, above Lima by about 50 miles. I haven't been to the port, but I've been to Peru in January, and it was fantastic to watch what they're doing on private and public water storage when I think about Sigma and the lack of water storage in California. And what they're enabling growers to do on top of that with far less regulatory requirements to get private water storage. So Peru, like everywhere else, is challenged on groundwater and surface water, but they're fixing it with intelligent policy decisions and budget decisions. And if you go back on the ports, for those of you that haven't seen the port of LA or the port of Long Beach, they are train wrecks. They are outdated. They are underinvested in. They are not automated. The unions have basically won in that port system, and we are a reflection of that. Because of that, they are two of the most inefficient ports probably on the planet at this point. But I know in some surveys of North America, South America, they rank near the bottom, and we just haven't done much to invest in them or get the labor situation improved so we can do more. So new port in China, shiny automated port in China, much less of a labor situation for them to manage. And China and Peru doing a great job on managing that port and getting it open on time, on budget. And here we go. The economic development focus, when we met with the government folks in Lima on our trip to Peru with the Western Growers Delegation, the only two categories they're investing in are ag and tourism. And what does an investment look like? Take a look at the booth on the left. This was from IFPA. And yes, IFPA will be involved with this. We know those folks. I work with Vonnie Estes, the innovation head over there all the time, good friend. And they will be part of this. But look at the IFPA show. 25,000 people in Atlanta a couple weeks ago. That's a 40 by 40 booth called Avocados in Peru. They are not asking for permission to take our growers from us and move them down to Peru. They are just moving them with aggressive trade show stuff. So this is what's going on in Peru relative to the California experience. And you can see why it's getting a little tougher to farm in California. So last couple points on this. Macro view, the reason California is in extra trouble is if you grow up like I did in California and you move from a small town in Salinas Valley to the Silicon Valley and you spend 25 years up here in tech startups before you come back to ag tech and watch those two worlds get together the last 10 years, you realize that what propped up the California economy and what allowed us to make so many bad decisions for so many years in a row was Silicon Valley. Right. So we had Intel, we had Cisco, we've got Apple, we've got NVIDIA, we've got the cool kids, right? We've got Oracle, Google, Facebook, and OpenAI. All of those ecosystems are within 50 minutes of my house, right? And all of those built a great California economy that is still, awesome, but not as awesome as it could and should be, because increasingly founders and builders are choosing different locations. Look at all of these sectors. I would argue we would have led in these sectors 40 years ago, probably even 30 years ago. But crypto, now in Colorado, right? We don't lead. Data centers, Virginia puts in more square footage than California. We don't lead, right? Autonomous vehicles, Governor Ducey said Arizona, we want to lead. We haven't matched that yet, right? Drone air taxis. Joby picked up sticks from Monterey, left us some subassembly manufacturing jobs. Okay. Moved to Dayton for 2 million square foot of high-end avionics, right? And SpaceX and Twitter, Tesla included, all took off to Texas when Elon relocated, right? The loss of Elon in California cannot be underestimated, right? He's the coolest guy on the planet from an innovation standpoint. He chose to pick up and leave California. That's going to hurt, right? And finally, AI leaders are increasingly investing in nuclear. Microsoft with 3 Mile Island, Amazon with Susquehanna, they want to reopen. And Google wants to build new small modular reactors all over the place, because power and water being cheap, abundant, and reliable, that 3 Mile Island plant, 3 Mile Island 1, not the one that had some problems back in the 70s, but 3 Mile Island 1, that does 800,000 houses worth of power. And Microsoft wants it all for AI, just to give you guys some scope. So that's the challenge around California. We keep running the founders and builders that build the great companies to other places, and we will pay a price at some point. I would argue we're paying some of it now. We'll pay more of it going forward. A little bit more on that. The big stat on this page, 352 companies with over 100 employees have left California and 0 have moved back in. So it's tough. You see some of the companies that have left, and our job growth in California is just way too high on the government side. Hoover Institute will tell you that we had job growth of 156,000, but 96% of it's in Sacramento. That's too many. That's not a healthy economy. So last 2 slides, what ag policy decisions will help ag tech innovation? First, protect the acreage. That protects the rural economies. It's already been talked about. I grew up in the Monterey County area. My dad's ranch was in Imperial Valley. I know both areas pretty well. We have done a terrible job of taking care of those rural communities by allowing the acreage to move at scale that they rely on for their economy to stay vibrant, right? It's not just the ag, it's the ag tech and the production behind it that made those work. And it's been really sad to watch the Imperial Valley, parts of it disappear in real time. What do we need? We need water policy, even today, more storage, more maintenance of dams. The dams near my ranch, Nacimiento and San Antonio out in California, very poor maintenance, very poor infrastructure maintenance. That's costing us annually and daily in some cases. More storage needed, more desal is needed. We got a huge coastline with desal possibilities, doing a terrible job of managing that asset. Energy policy, we need a portfolio approach focused on price, availability, reliability, the stuff that the nuclear folks are thinking about as they reopen and try and launch new nuclear plants. We need to make energy cheaper and more available for everybody in the state, including ag. And finally, we need to fix the ports. We need to fix the roads. And an economic development focus wouldn't be the worst of things, right? So there's a big F3 grant of 65 million from the U.S. Department of Commerce with metrics around acreage, jobs, and GDP. You don't want the grants focused on innovation and startup metrics. You want it focused on ag and ag tech metrics, and that's what these grants are doing. We're working with partners on more, but the big part is just, again, protecting the acreage keeps those rural economies vibrant. If you don't do that, they all go away. Last thing on ag tech, focused on commercialization, later stage startup life cycle. That's where we need to make all the action happen. We're capital constrained, so we need to get the stuff that's near the 50-yard line into the red zone and into the end zone the next 5 years. The stuff that's down near their own goal line, they're on their own for now, right? We need field trials, case studies, economic templates at scale. We launched with partners Reservoir Farms to give robot incubators a real life place where they can set up shop near fields to test and demo 24/7, 365. That rolls out next couple quarters in Merced and in Salinas Valley. And then identify problems that are not large enough for venture capital funding, like everything that's not harvest and strawberries, because harvest is 90% of the hours. Quick overview on that model. The Strawberry Commission takes industry dollars, funds R&D engineers at Cal Poly Strawberry Center, now 10 years old with an 8-year Strawberry Day exposition history that's awesome. And they get those projects to commercial phase with local solution providers, all with interactive feedback from the growers, no venture capital required. We're working on similar projects in vegetable. First one will be probably leafy greens. We'll get going in the next 3 to 6 months, and ideally at Cal Poly. I'm a proud alumni. I'd love to see them get the business on that one. And finally, we need a ton of ag tech enabled workers, Western growers working hard with CDFA and some grant funding to get 3,000 of them out in traffic over 4 years and build a program that scales across so far 15 on its way to probably 30 ag tech community colleges. Happy to help scholarship them, happy to put a mobile app together to get them tracked and make them available for employers, but we need more. We can't find them fast enough, and we'll need even more of them as AI emerges. And finally, last question for the policy folks. Why do we have CARB paying $110 million for EV subsidies for tractors? I mean, I know why we say it is. Why don't we have that for all automation tools? Open question for Sacramento. So with that, sorry, going the wrong way on my deck. I will give you guys my contact information. Happy to keep the conversation going. I'm on LinkedIn a ton. Love to see some follows over there. And we're launching a little effort with some partners of mine called AgTech Alchemy, where we do live events for the startups and investors to get together. Some of you have been to those, and webinars are coming. We really want to do what we can to help these startups because the capital constraints are real. And I've had way too many calls from friends who are shutting down companies this year, and it's not been fun. So we do what we can to help out. And with that, I'll open it up to questions and pop the chat open. Thanks for listening.
Thank you, Walt. Tracy has a question. Tracy, go right ahead. All right, while we're waiting for Tracy, we had one question in Q&A. Are the automation solutions that are being built, i.e. spraying, weeding, aligned with the regen ag trends?
I would argue maybe not. I mean, ironically, the organic lack of inputs, which a lot of regen practitioners also practice, creates the opportunity for them, right? So the lack of labor creates an opportunity for them. I think it's a separate set of tools that does the regen stuff, right? That does the soil health stuff. What we are seeing is a lot of solutions around soil health, a lot of solutions around soil monitoring, a lot of solutions around stuff. I would say the closest where they're aligned is obviously as these weeding and spraying and other robots go down the field, they have a lot of imagery that they capture, and we're working to get some of that imagery turned into solutions that that other growers can use to do regen. So I think of the automation solution as the labor problem solver, with data from it being used to help accelerate regen is probably the right way to think about it.
Right. And we have one more question that we can fit in before we need to move on here. Plant-based protein seems like a giant growing demand. What do you see for supply, particularly non-soy?
No, I would agree. I think plant-based proteins have a place. I think, again, the challenge for a lot of the alternative protein space is they came in with a big, swinging scythe, saying they were going to take on all the livestock folks and beat the heck out of the cattle growers, raising my hand. And they played it badly, right? They didn't realize they were going to have a hard time hockey sticking. So the fact that they burned through all the capital that they did as fast as they did burns them with investors now, right? So I think if they were starting from scratch from a standing start, they'd be better off. I do still think there's an opportunity to get some of that plant-based protein stuff into market. We are still seeing funding for it. I don't think a lot of the players that are on the field now, this is true of vertical farming as well, I don't think there will be good outcomes for a lot of them. There will probably be two things that get this space entertaining. A couple of folks will figure out how to make a model out of this and get it to retail effectively. Those will generate some capital. And a couple of folks that are on the scrap heap of startups that didn't make it will have some assets that are bought cheap that you can either do roll up or recommission and repurpose toward other places. And an asset that's not a good asset at 100% of purchase and investment price that can be bought for 5 to 10 cents on the purchase price can be a great asset for the second or third owner. So I do think there's some stuff that'll happen there. Again, vertical farming and all protein. So we watch all protein closely, and we're fine with it. I think it'll get its share of the market. I'm just not sure how much that is, because again, the unit economics on production and at retail have to work. You have to compete at the retail level on price and quality. And I wrote this 3 years ago. If you don't win on taste and you don't win on price, you are done. You are done. You can't just put a product out there and expect people to buy it because it's plants.
Go ahead, Katie.
Hi, everybody. Sorry I had another meeting. It didn't until 11 today. Well, I feel like I just went through a massive masterclass in all sorts of things. It's also coming off the heels of, I was just in Salinas at Tanimura and Antle for a day, which was huge, massive class in ag and how ag is done well, but the challenges in California. Scott walked us through all those challenges you mentioned. I've also spent time with John from Apricot, the biggest little farm family recently, which is also a California farm. But just looking at the nuance between like the sledgehammer conversation of regenerative, looking at what the big farmers are facing, also in the ag tech space. I guess you gave so much information, like it was so dense, and the economic development professional me wants to like take that, slow it down, map it out, and really create.
Katie, Carter made me do it in 15 minutes.
I know he did. But I think I think there'd be an enormous value. Like I would love to sit with I'll fly out to California. Like, let's take a half a day. I'd love to map that out and create the 5 to 10 year strategic plan for economic development that really peels back all those systemic onion leaves that you just mentioned, right? Because there's a lot of layers to what you just talked about. And then there's healthcare chat happening, and Carter was talking about healthcare. There's all these other related, like I say, you're this North Star of ag, but in the North Star, there's a constellation of other systems that are related who need to understand how to connect the stories more broadly.
I'm coming to California too.
Are you going to, Ellen? All right.
I'm coming too.
And I think there's a way to build an economic development strategy that puts language, understandable language in everybody's presentations, where we start to connect the dots. Because someone in the healthcare space hears what you just did and they're like, my mind's exploding. I don't know quite how to connect the dots, but I know there's something there I need to care about. So, and Aaron, you do a great job of slowing that down, but I think that there's just an opportunity here that I don't want to lose. And I'm so grateful, Walt, for everything you said. But I'm so appreciative recently that there's so much nuance in what we're talking about. And I am sick and tired of the sledgehammer approaches of plant-based, regenerative, all these big terms, food as medicine. Like, I'm just tired of the giant terms being shoved down everyone's throat, like these panacea solutions, without understanding the little itty bitty nooks and crannies of the complications. So just kudos to you in bringing out the complicated parts, the messy parts that we don't want to look at as we're trying to shove these big things down people's throat as systemic solutions.
Appreciate that. You guys are all welcome to come. California's open for business. I love showing off ranches. I got a big car. We're ready for you. Yeah, come on out. I'll show you my ranch. I'll show you Salinas ranches. You've already talked to some of the guys. No, the California growers have seen some of this tech. This tech is everyone's, by the way. It's open source. I made it available for all. I posted on LinkedIn. I am happy to have folks telling the story alongside me, and I'm happy to tell the story directly when I can. So no, the slides are out there, and if you guys want them, ping me and I'll give them to you directly. But no, this story deserves to be told. It's taken a long time to get here, and only when I talk to my growers for as long as I have, and talk to the startups and the capital guys for as long as I have, and then for me, the week in Peru was eye-opening. You go down there and you actually see them growing down there, and you're like, yeah. And here's what I'll leave you guys with, and I need to get more. Aaron's great at like quicker sound bites, but I'll give you this one. Trade policy may matter more than innovation policy the next 20 years for rural economies, because it's not monopoly where you keep doing laps, building houses, building hotels and collecting $200. It's a risk game. And the risk pieces are already on the board, and we're losing ground to Peru every single day. Good on them. Shame on us. If we don't change some things, it will only get worse. Those numbers I showed you, the 9 million acres lost and the 45,000 farmers, those only get worse if we don't make some changes. That's a straight line projection that doesn't factor in all the last 10 years of policy at a higher impact factor, but it'll be a higher impact factor, I'm confident. So yeah, happy to keep the conversation going, and glad you guys are with me, and let's just keep things moving. There's opportunity, big opportunity.
Thank you, Walt. With that, we're going to turn it over to Dr. Joe Pisorno to talk next.
Okay, my screen okay here?
Yes.
Thank you. Well, thank you for the invitation to join you. But more importantly, I want to thank the whole community and all your staff. You're engaged in something that has been near and dear to me for a very long period of time. Way back in December 1969, I read a book on health and diet written by a naturopathic doctor, and it changed my life. And I became a vegetarian and started eating organically grown food wherever possible. And those of you who have been around for a while know that organic food 50 years ago was based on, eating it was based on faith. It was hard to find. It was cosmetically not very nice, but it did taste better. So thank you all for joining this revolution that's been going on for a very long period of time. And I'm excited to be here with you. Now, my presentation today is going to be a little different. And that is, let me talk about the personalization side of this. These presentations so far have been great about how do you make the food supply healthier and safer and less polluted, et cetera. I want to talk about the next aspect of this, and that is how do you help people make behavioral change to follow this great guidance that we're providing them. But I also like to say, when we say food is health, I want to change that a little bit to say low toxin, nutrient rich food is health. Because unfortunately, the food that's being sold to people today, while it is keeping them alive, it is dramatically increasing the disease burden. So when we look at what are the determinants of health, there are basically four key factors. Person's genetics, hugely impactful, but genetics only accounts for 15% of disease. 85% of disease is determined by people's behaviors, and even that genomic susceptibilities is modifiable by really smart nutrition, because if you can understand exactly where a person's genetics are a bit weak, we can provide nutritional support to strengthen that genetics. You look at the environment. We have now polluted the environment with so many metals and chemicals that the primary causes of diseases have moved from nutrient deficiencies in the past to now nutrient deficiencies plus environmental toxicity. And when we talk about nutrition, it's not just the vitamins and minerals. The 43 elements and minerals and vitamins and fatty acids and things, 43 have been decided as being important for human health. But in reality, they're only required for human life, because human health depends upon all the other molecules in food. You ask yourself, how many other molecules are there in food? There are about 10,000 other molecules in food. So basically, we only look at a very small percent of the molecules in food, decide if grow foods chemically maintain those molecules were okay, and the other molecules are not important, which is why I've now written 3 editorials in PubMed on unimportant molecules. And finally, we have lifestyle. People's behaviors are important. So we look at what are the foundations of health. Health depends upon physiological function. Diabetes, what is diabetes? Diabetes is loss of blood sugar control. And when you lose control of blood sugar, all kinds of bad things happen. Diabetes now accounts for 1 out of 4 healthcare dollars. When I started practice as a naturopathic doctor way back in 1975, I was so excited when I saw my first patient with diabetes after 6 months, okay? Because it was so rare. 1% 50 years ago. Now it's 15%, and 1 out of 3 people are projected to get diabetes. All about loss of physiological control. So why is this happening? So first off, you have to look at the basics. I find quite humorous when people talk about biohacking. I say, biohacking, oh really? Are you eating organically grown foods? They say, no. I say, I don't care what biohacking you're doing. It's not going to have much impact because the foundational things aren't there. Everybody has to eat healthy food. We have to exercise. We have to avoid toxins. We have to have loving relationships. We have to get enough sleep. Lots of things we can talk about. But there's more we can do. We can enhance this by understanding each person's unique physiology and what do they need to do to be as healthy as possible. And we give people personalized guidance on what's most important for them, they will make behavioral change. When you give people generic guidance, you don't get much behavioral change. Personal guidance, you get change. So change depends upon personal choices. So behavioral change is hard. It's very, very hard to do. And people are swamped with generic health messages, but they get about 1,000 times more health damaging advertising. And living life optimally requires a lot of effort, exercise and good healthy diet and avoiding toxins, et cetera. Difficult. The costs are immediate, but the benefits are delayed. So how do you get people involved earlier on? It turns out personalization. We tell people what they need based on their unique physiological function, they will make behavioral change. So now how do you tell people what they need? Well, it's really complex because human physiology is hugely complex. Our bodies are enzyme machines. Those enzymes are created by a protein determined by our genetics, but that protein is inactive until it has the right vitamin or mineral to make the enzyme work. Well, not only do we have deficiencies of vitamins and minerals necessary for the enzymes to work, we have deficiencies in the other molecules, flavonoids and things like this, that facilitate the activity of the enzymes, and we are poisoning our enzymes with metals and chemicals from the environment. So there are about 5,000 enzymes. There are about 3,000 single nucleotide polymorphisms in how people make their enzymes. There are 250 nutrients known to affect human physiology, not just required nutrients, but other things like flavonoids and carotenoids. And there are at least 175 metals and chemicals at high enough levels in the environment to have saturated or put enough levels in our bodies to basically poison our physiology. The primary driving factor for disease is the environmental toxins. And by being nutrient deficient, we're even more susceptible to them. So vitality and disease risk are determined by how well these enzymes are functioning. Okay. So how much individual variation do we have? Well, we have a 10-fold variation in the amount of specific nutrients people need. I did a study where I looked at over 1,000 articles of vitamin D, trying to determine what was the optimal level of vitamin D for people to take. It ranged from as little as 800 units, yes, that's above the RDI, to 10,000 units. Huge variations because of people's genetics. Then we have a 1,000-fold variation in how well we detoxify the toxins we're being exposed to. And finally, we have about 10-fold variation in how susceptible people are to environmental toxins. This is all hugely personalized. Here's an example. Here's an example of B vitamins, B6, B12, and folic acid. When we look at the level of these things in the blood, according to the normal ranges, only about 6% of people are deficient in these vitamins. But we look at the abnormal metabolites that build up in the body because they don't have enough nutrition based on their genetics and toxic load. All of a sudden, look at this. We go from only 6% being deficient to 63% being deficient based on what their body needs. Okay, and why are these nutritional standards so problematic? because they ignore biochemical individuality. Okay, but it's more than just that. Look at the environmental toxin. I just found this study, which is incredible. This study tried to look at what is the effect in the body of the total toxic load. So basically what they did is they looked at 43 different toxins. They looked at what physiological damage they cause, and then they tracked what happened to people over a 10-year period of time in terms of how well was it physiologically working according to their toxic load, and what happened to them in terms of death rate and disease rate. Look at these numbers. So this is, they have something called the relative wellness index, okay? Whereas you want it to be 100, where everything's perfect, where 0, you're basically dead. They then looked at over a 10-year period of time, what happened to people. This blue line are the people who had the lowest physiological function, about 40%. 80% were dead within 10 years. Whereas conversely, those who had the higher, better levels of physiological function, very low progression to death. Same thing when you look at disease. They looked at disease burden 10 years later. Look at these people with the lower 40%. Look at their disease burden, but look at the people over here with high levels of physiological function. Essentially no progression to disease. This is what we're about. We're about giving people the nutrients they need and avoiding the toxins that are poisoning their bodies. So if we're going to deal with the real problems of health and disease, we have to look at what the real causes are. Here, look at diabetes. We know as people's body weight goes up, their incidence of diabetes goes up pretty dramatically. We see things like here, a 40-fold increased risk of diabetes, 93% increased risk of 93-fold increased risk of diabetes. These people all have diabetes, it just hasn't been diagnosed yet. But even though we know people with obesity have dramatically more diabetes, what happens if we look at this a little differently? Let's look at people and let's look at their body mass index. You know, how fat are they? Let's look at their body load of diabetogens. That's what researchers are now calling these things. They're calling them diabetogens. What do we see? Okay, look at this. You have obese people, look at this, dramatically more diabetes as you get more and more obese. Well, what happens if we look at the toxin load? If that fat is not full of diabetogens, they don't get increased incidence of diabetes. Conversely, over here, we have this lean person, less than 25 body mass index. Even though they have good body mass index, look at this. If they have high body load of diabetogens, they have diabetes. And by the way, this is not risk of diabetes. This is incidence of diabetes. 35% people in the top 20% of body load, even if they have good body weight, have diabetes. If they're overweight, it's 60% have diabetes. Okay, so it's start looking at then, what are the toxins causing diabetes? Arsenic coming from the water supply, BPA coming from food packaging, DDE, well, that's DDT breakdown product, toxins, PCBs from eating farm fish, phthalates, okay? Phthalates from all the plastics we're being exposed to, health and beauty aids, things of this nature, and here we have air pollution. Okay, so as you can see, the primary cause of the diabetes epidemic, which is costing 1 out of 4 healthcare dollars, is environmental pollution. Where are the toxins coming from? Folks, the majority of toxins coming from food as it's produced, the food containers, food preparation, food transport, etc. That's water, air, health and beauty aids, and house and yard chemicals need to decrease in order. Okay, so now we need to empower consumers to make the right choices to promote their health. Okay, how do we do that? We do that by giving them the knowledge and technology they need to make good choices. But we do that with also the use of artificial intelligence systems to guide people on what are the most important things for them. Okay, so it's all about how do you promote physiological function. It means analyzing the effects of genetics, nutrition, toxins, etc., determine where there's physiological abnormality, determine why it's happening, and give people the right guidance they need to reestablish their physiological function. And we give people personalized guidance, not only they make changes, but they make changes that improve their vitality and decrease their disease risk. Okay, so does this work? The answer is yes. Our technology has now been used with 20,000 users, 4,500 employees in an oil production company in Canada, 10,000 employees in a university with multiple campuses all over the world, and with an insurance broker who had 11 small self-insured corporations. We're able to track the data with these folks, and the answer is they get healthier. So this is looking at, in this large corporation of 10,000 employees, looking at the same individuals over a 4-year period of time, and these red is the high risk. We decreased people in the high risk going from here to here, decreased high risk, decreased medium risk, and we doubled the people in the low risk category. Okay, so we dramatically decreased their health risk by giving them personalized guidance. So what happened? Okay, so look at the same individuals, looking at the disease risk, look at things like heart attack. Percent in high heart attack went from 7% to 3%. People with diabetes went from a 25% risk down to 17% risk. And how did this happen? Because by giving them guidance, they made behavioral change. We got them to decrease smoking, improve their sleep, decrease their stress, improve their exercise, improve their diet, eat more fruits and vegetables, eat healthier fish, avoid bad foods. Again, all we did was say, here are the things that are most important for your health. Here are the things that are damaging the most. You make the changes, and they did. Quite remarkable. Okay, so now the idea of health, artificial intelligence for health sounds like a good idea. Folks, it's hard to do. We had 3 companies we had contracts with who said, wow, this is great. We don't want to pay your fees anymore. We're going to try to do it ourselves. They each spent actually it should be 1 million, not 10 million, $1 million. They all failed because this is hard to do. Now, some of you may be thinking, well, we can do AI with big data. Oh, well, big data will work in some areas. That's exciting. But most people don't realize that the big data is based on the research that's in PubMed. The research in PubMed is based on the disease model. Okay, we're talking about the health model here. And that does not fit very well with how the vast majority of research is done. So there is research on health promotion that's useful, but not very much. But what most people don't realize is the huge amount of fraudulent research in PubMed. I'll give you 2 examples. Fish oil. So huge study came out about 5 years ago that fish oil does not work. And it was double-blind, placebo-controlled study, looks like it should be good. But then when you look at the research, what they found was that they compared fish oil to olive oil. So they compared one effective natural therapy to another effective natural therapy, and because it was not better, it was defined as failing. At the same time, research was published with a brand new prescription fish oil, and it was shown to be really clinically effective. But you look at the study, they compared fish oil, their synthetic fish oil, to mineral oil, which is actually toxic to human beings, in order to show that the synthetic fish oil was better. Another example, statin drugs. Huge study, 10,000 person, double-blind placebo-controlled study showed that statin drugs should be given to everybody because the risk of an adverse reaction was less than 1%. But when you look at the study more closely, you realize that they started with those 10,000 people in an open trial design. They meant that all 10,000 people were given the statin drug. Then anybody who had a reaction to statin drug was removed from the study. And then they compared those that were left, not much toxicity. How many people were removed from the statin study because they had a reaction to the drug in the open trial portion? 3,000. Okay, so you look at that study with AI, you say, oh, wow, statin drugs should be given to everybody. No, because the 30% had adverse reaction were removed from the study to get fraudulent results. There's study after study in PubMed that shows how problematic this is. Okay, so in conclusion, we've created an artificial intelligence system that'll help guide people to make the healthiest choices for themselves based on their unique biochemistry. I'm happy to say we already have 2 members of the organization involved with us, Ovum Health and the Health Flourishing Collaborative, and I hope the others will be interested in joining with us as well. Our job, we are an artificial intelligence health company. We provide tools for other people to use, and we'd be delighted to work with you. So you can access me either through my the Genesis email or through my personal email. And here's my phone number. Love to have any questions you may have.
Thank you, Dr. Joe. We have Zoe with her hand up. Go right ahead.
Oh, and by the way, I'm a true believer too. I grow as much of my own food as I can. Please.
Zoe, did you have a question? Oh, her hand's down. Katie had made a comment about that we need to be able to easily and cheaply test humans for toxic load.
Yes.
You move this forward from a regulatory standpoint. Can you talk a little bit about that?
Oh, extremely good question. I was just asked to create a 5-hour intense course on for doctors on how to assess toxic load. And as I dove into it, I realized that trying to test for individual toxins is going to be very, very hard. There are now 83,000 chemicals approved for use in the United States. We can only measure a few hundred of those, and even at that point, they're expensive and not very reproducible. So what I have instead decided is what we should do is we should ask people if they are doing things that are exposed them to toxins, and if they are, let's measure how much damage there is in the body. For example, we can measure people's kidney filtration rate, called EGFR. It turns out that EGFR goes down in proportion to toxic load. Every environmental metal and every environmental chemical I looked at, as the body load of those goes up, so that the EGFR goes down. So I've now realized that there are basically 4 laboratory tests we can run to determine who are most damaged by environmental toxins. They are a liver enzyme called GTTP, and what that enzyme does is it recycles glutathione in the body. Our smart bodies, when we're exposed to environmental toxins, we recycle more glutathione to protect us from those toxins. Well, it turns out within the normal range, GTT goes up in proportion to toxic load. So normal GTT range is 10 to 60. Well, it turns out it should be between 15 and 20, because anything above 20 is direct proportional to toxic load. Great screen. Another one I do is liver enzyme called ALT. ALT is very sensitive to liver damage. It turns out ALT goes up in every environmental toxin that I've looked at. And then I mentioned EGFR is a good one. And the final one is a urinary test. By the way, all the 3 of these tests I just mentioned, any standard lab will get it for you. The other one I found now is called 8-OHDG, and this was measured in the urine. It's a measure of DNA damage. It turns out that the more toxins people are exposed to, the more DNA damage they have, and it shows up in the urine. And then when you help people remove their decrease their toxic load, one way you monitor it is what happens to 8-OHDG. 8-OHDG goes down, GTT goes down as well as toxic load decreases. I know a long answer to your question, but I just figured this out this last week, so I'm really happy to talk about it.
Thank you very much. Is there any other comments for Dr. Joe or questions? Oh, Katie, go right ahead.
Can I just follow up on that, Dr. Joe, really quickly? I mean,
Please.
I mentioned something about social determinants of health in the chat. I just think as we think about patients who have many social determinants of health, you know, that they're dealing with, as a former land use planner in toxic neighborhoods with multiple brownfield sites, without healthy food, with high asthma rates, with contaminated waterways and fish tissue. Yeah. There's so many things that people in these neighborhoods are coming at them. Their toxic loads had to have been causing high cancer rates, all sorts of different things. But we don't, there's nothing. I used to go to the doctors, the hospital, and say, I want this person's address with all of the chemical load exposure potential in this neighborhood to be in their health record. Because shouldn't we be using our public health dollars to be able to especially treat, diagnose, do interventions, knowing that there's toxic pathways here? To your point, if we can't test everybody, we're going to have to make some smart assumptions. And I just think in a country with, and Tamara, I see Tamara on the chat, you know, Tamara and I talk about how we have a shrinking population, we have a shrinking workforce, we need all hands on deck. Our military has a shrinking enrollment, and yet we don't say to ourselves, wait a minute, we have sick people here who we need to be able to test for, need to be able to address. We're treating people as disposable. And I think that this toxic contamination story of people is a way in which we're treating people to be almost disposable and not taking the time to say, this is a productive member of our society that we need to heal. And it can't just be for the wealthy that get to detox themselves.
Great. I 100% agree. Very well said. So I just completed a project in Flint, Michigan. So people are aware of Flint, Michigan because of the lead crisis that they had. So I got together with a Black integrative medicine MD friend of mine. We went to Flint and said, you know, are there 20 minorities here with early diabetes who'd like to try detoxification to improve the blood sugar control? And I learned a lot. Number one was how engaged the community was and wanted to be healthy and didn't know how. That was very exciting. So when we went there, I did what you said. Oh, I had the same perception you had, and that is, well, what's their toxic level? So it turns out that the state of Michigan has analyzed the arsenic levels in the water throughout the area. And in the area where Flint, Michigan is located, which is Genesee County, 43% of the public water supplies in Genesee County had arsenic levels known to cause disease in humans. Okay, so so one of the things we did, we analyzed everybody's arsenic levels, and sure enough, we found plenty of arsenic. So we were able to teach people how to decrease their arsenic levels, and decrease their arsenic levels, their HbA1c went down. Just simply by saying, here's what you do to avoid the toxin, and it was very effective. I think there's a lot that can be done. Minority communities are hugely disadvantaged because they increase toxic load. And when we went out to the local grocery stores in Flint trying to look for healthy food, there wasn't any. It was hugely challenging. We had to work with the local, there was a few local organic farmers, and we were able to connect them with the people in our part of our cohort here.
Great.
So thank you all for your attention.
Yeah, thank you very much, Dr. Joe. And again, we're going to keep this conversation going. So next on the agenda, we have Rocky Massey and Mike Biaggi. Bree, I see Rocky's not on yet. Do you want to take it away?
He's been pulled into meetings, so I'm actually going to just step in for him. Let me share my screen and pull our deck up. All right, and Mike, I see you've joined also.
Yes,
All right, so hi everybody. My name is Bree Lowry Cox. I am with GRC Advising, but I advise the executive team at Appalachian Regional Healthcare. And we're going to talk today about healthcare policy. We've heard a lot about agriculture and some of the implementation, but this is going to be from policy perspectives from a nonprofit rural healthcare system who is leading in both food is medicine and food is health in their community development, but also making a great big wave at the state and soon to be federal level. So Mike, if you want to introduce yourself.
Sure, my name's Mike Biaggi. I am a lobbyist, partner with the Rotunda Group, a firm based in Kentucky, focused heavily on state government relations here in Kentucky, but also do work at the federal level as well, most closely with Kentucky's congressional delegation, and also through other relationships. My background is that I, from Kentucky, worked on Capitol Hill on the Republican side and in various Republican campaigns throughout the first 7 years of my career. And in fact, the last job I had in DC was for then Congressman Bill Cassidy, now Senator Cassidy, who's going to chair the Senate Health Committee here starting in January. But I was his legislative director for his first term in the House. And then I decided I want to get back home. And for about the past 15 years, I have been here in Kentucky and been with my firm and doing lobbying and advocacy and government relations for the past 7.5 years.
Thanks, Mike. I think it's going to be powerful to hear some of Mike's perspective because we hear a lot about the advocacy power of big pharma. And I think to hear a healthcare perspective will be important, especially because rural health is one of the areas that will be the most impacted by everything we're discussing today. So quickly, this is a snapshot of who Appalachian Regional Healthcare is. They are a fully integrated medical delivery nonprofit institution. They have 14 hospitals, 6,700 employees, gross revenue of over $4 billion. They serve some of the sickest population in the country with a payer mix that is 80% plus Medicare and Medicaid. This is just a way to understand who we're talking about, where they are geographically very spread out. They own 300 doctors and have a medical staff of 1,300 and a population of about 350 patients. So as we discussed today, this is who we're talking about. ARH has been a leader in some health priorities tied to food is medicine and food is health. I do want to clarify that there is a dual track here. Food is medicine we consider on the clinical side, and food is health to be something more community-based and a little bit higher up on the population health totem pole. So protecting rural health and protecting its access is a key to how Mike works and how the healthcare system works. From a policy perspective, ensuring that people have access to the care, critical access hospitals, and taking care of sick people is a way that they make their money. Moving forward, they are looking at broadening their reach with mobile care. This has been funded at the federal level by the Appalachian Regional Commissions for grants totaling over more than $1 million that I have had the privilege of writing and also implementing. Some of you joined us when we had this conversation in October. We shared some of the proof of concept pilot programs that are happening through cross-sector collaboration, and they are very, very powerful. Now, that is not a direct policy straight line. It's a dashed line to say, here's what's possible, to Carter's earlier point about a test bed, an innovation lab, where you have some of the sickest population with some of the most social determinants of health of any other population across the country. Now, in terms of what is not working, there is a disproportionate rate of preventable disease causing comorbidities and sick care. And as we all know, this could heavily be attributed to food, convenience store food, lack of grocery stores, lack of access to fresh, transportation issues, and the socioeconomics of the region. The other thing that we believe is something that's not working, that is only allowing things to be functional in small pilots, is that food is health and food is medicine. It's all philanthropically funded. Again, this is a nonprofit healthcare system. Federally qualified health systems and community health centers have a wonderful opportunity because they have federal dollars. As the safety net provider for the region, this is all philanthropically funded because there is a belief that this is the way to get ahead of some of the moves to value-based care, but also to continue to do more for the community because the people are just continuing to get sicker. We are seeing positive outcomes. We are seeing A1C improvements, and it is finally getting some traction at the state of Kentucky level and above, obviously. Aspirations and implementation, ARH CEO Holly Harris, who some of you have met, is a passionate advocate for prevention and lifestyle medicine implementation. There's nowhere to go but up, but the de-prescription model and also getting people to go back to the basics of their lifestyle habits and behavior change when you have multi-generational households and people that cannot afford their medication is a really important piece of this puzzle. So this is the landscape of the priorities that ARH is marching with. They have proof of concept across each of their 4 regions, and we work to really satisfy that beautiful pyramid that Aaron has shared, and I will come back to some of that in a moment. But I'm going to turn it over to Mike to talk about, as a healthcare lobbyist, what that looks like based on ARH's position and some of the successes that he's had and the road bumps that he encounters.
Sure. Thanks, Bree. And let me say up front, Bree invited me to join this, and I was glad to do it. But I said, Bree, I know the topic is food as medicine, and nutrition, and it's like many of the issues I've worked on for ARH haven't been as focused on that. It's been rural healthcare broadly, and also those issues. And Bree said, that's fine. There's plenty of great perspectives on this webinar about the food as medicine. Let's share what we have been working on, what's been successful, what's been challenging, and frankly, some of the strategic approaches we've taken on the issues we've chosen to do. And it's been, over the past 5 years, ARH has really worked to grow its influence, with elected leaders, with government leaders, so that it can influence policy and get good outcomes for the people that they serve. So that's been through policy and the legislation, mostly at the state level, and then here just very recently have really taken our model of what we've done at the state level and started to look more at our relationships and what we're doing at the federal level. But mostly in the state of Kentucky, through legislation, through regulation, through executive branch decision making that is not necessarily regulatory, but is critical for decisions that impact rural healthcare and how health systems operate, and then also through direct appropriations for some key projects in the region. To give some examples, Kentucky worked with our state association to pass the Hospital Rate Improvement Program, which was a method for Kentucky to draw down additional federal dollars without additional state commitment, but just federal dollars to pay a supplemental Medicaid payment to hospital systems in Kentucky, especially those that had a more challenging payer mix. And then that was about 4 or 5 years ago. Then in the last state legislative session, worked to have like an additional rate improvement on top of that that was specifically for rural hospitals, rural healthcare systems, again, where it's, where we have, especially in Appalachia, some of the highest rates of poverty, some of the most profound health disparities that you'll find anywhere in the country, not just in the state, but anywhere in the country. We were successful in doing that in a way that lawmakers knew would be beneficial for the region, and in Kentucky's case, didn't have to come with an additional state contribution to draw those additional federal dollars. Issues of provider shortages in Eastern Kentucky and in rural Kentucky are an ongoing issue. We just don't have access. The health systems don't have access to as many providers to employ as are in other places, and it can be challenging to convince providers, well-educated, high-paid positions, to come to Eastern Kentucky to serve there. Many of the providers we have are folks who are homegrown and who wanted to return home, usually after getting their education somewhere else. But you can see how that would be a challenge. And we've dealt with that in a few different ways. One was recognizing a shortage of nurses, and that our nursing schools in Kentucky were kind of constraining the number of applicants and nursing students that our Kentucky nursing schools would allow. We worked to reform our board of nursing at the highest level to ensure it was more reflective of the variety of players out there, including health systems, that they needed to have a voice in how the nursing pipeline played out through applicants, through education, through standards, and ultimately getting them into their work in the hospital systems. Work to reform the nursing board and ensure that a larger applicant pool was being allowed to apply for the number of nursing slots in Kentucky. Again, knowing that Kentucky needs to rely heavily on its own homegrown pipeline of providers, including nurses, to serve its needs in rural health systems. We are very protective of the certificate of need system, the basis by which for major investments in health systems, such as ambulatory surgical centers, there's a licensure process by which the state has to approve those additions and show a need for those in the community before those major investments can be done. And the basis for that is heavily it recognizes the fact that healthcare is not a free market system. It is a system in which the rates that a hospital system is reimbursed are heavily set by the federal government. I mean, certainly in the case of Medicaid and Medicare, but even in the private sector, commercial insurance, private insurance, those rates of reimbursement for services are heavily determined, influenced by CMS. So that if another provider were to come into a rural community where margins are already tight for a not-for-profit hospital system like ARH, if another provider were to come in and cherry pick just the most profitable services, it would be untenable for a rural health system to be able to continue to operate and stay afloat at all if left with those services that are and those payer mixes that are consistently underpaying the costs that it provides, the cost that is necessary to provide those services, right? I think you all know what I'm talking about, but there are some things that reimburse above, and some payers that reimburse above the cost of that. But many others, including the government payers, that pay below the cost to provide those services. So we've worked with our hospital system to preserve that while being open to modernization still around the edges that does make sense. At one place, jumping to another issue where ARH is needing to see some reform is a challenge in having emergency EMS service. That's one where we're working where a shortage of EMS providers and a challenging financial dynamic around our localities, our municipalities providing that is leading to some sort of reform needed to ensure that patients have access to EMS services when they're in an emergency, and transfers from hospital to hospital as necessary are available to them, again, in the moment when the patient has that. And right now we're having a hard time ensuring that in all cases, patients have that access, especially in rural areas. So removing barriers to setting up EMS service remains a priority. And then the biggest challenge for us has been passing some sort of tort reform, medical malpractice reform that drives up the cost of healthcare. I think Kentucky, for various reasons, I won't get into the weeds, but has had more hurdles than in most places passing that sort of reform. And it makes it less appealing for providers to work here, knowing that the cost of their malpractice insurance is going to be disproportionately high compared to where they may practice in other places. Last thing I'll mention is I said at the start of this about appropriations. You know, we have gone to our state legislature and are going to members of Congress now with requests for targeted appropriations for certain projects. You know, and historically in DC, they called those earmarks. That sometimes is seen as a bad word in DC now, and there is much more oversight on those congressionally directed spending projects than there may have been in some cases in the past. But ultimately, we've gone to lawmakers and helped them understand that key government investments in targeted projects can make a huge difference in ensuring access to high quality specialty services like cancer care. Cancer centers is one of our most recent wins that the market itself is not going to fund in rural areas, but putting those investments in key areas where there's a demonstrated lack of available service makes a lot of sense for improving healthcare outcomes in Kentucky. And part of the strategy in that, I'm on to compliment Bree and her team, is coming to policymakers with a very strong presentation. We've done analysis of the absence of care, how far a patient has to drive to go get care, analysis of the economic impact, which is important in rural areas. It's not the core reason why we make an argument. The core argument is about access to care and patient outcomes and improving those outcomes. But you know, policymakers do care about jobs in their community and that sort of thing. So coming with a very concise, well-presented argument for policy change or for appropriations has been key to that, as well as building ongoing relationship with lawmakers and with at every level, and doing that with our state executive branch and beginning to turn toward looking at HHS at the federal level and CMS toward how one of the largest freestanding rural hospital systems in Kentucky, with the challenging demographics, patient demographics we've described and payer mix, how we can be one of the most knowledgeable resources for information on all these issues and on food as medicine, nutrition, that they'll find anywhere in the country. You know, ARH, by virtue of having 14 hospitals in a certain cluster in a region, we can really do a lot of analysis, provide a lot of data, and be a test case for improvement on all these issues, better than almost anywhere else you would find in the country, and certainly in rural areas. So that's my update. I hope it was relevant to the conversation, and any of the Q&A, if you want to pull me back toward what you all been talking about, that's fine. If you want to dive deeper into what I brought up on strategy and other rural healthcare issues, I welcome that as well. But thank you for the invitation to be on here. It's a pleasure.
Thank you, Mike. So I'm going to close out the ARH bit by just mapping policy, care, incentives, and then the food as medicine, food as health conversation. Ellen, I hope that you appreciate this graphic because I think it really pulls together the different insets across the spectrum and layers reactive sick care to lifestyle medicine and healthcare against value-based care and fee-for-service and where we're moving along the spectrum. So this is a new graphic for our team, but tries to show the overlap where it fits and where the pieces are slightly disjointed. The last thing I'll say, there are some key folks I do want to recognize. The ARH CEO, Holly Harris, as I mentioned in the beginning, is an extraordinary advocate here. Also, in partnership with Commissioner Jonathan Schell at the Kentucky Department of Agriculture, he has set up an initiative that he works on with Holly specifically called the Food as Medicine Initiative. We've also launched the Farmer Care Initiative to close the feedback loop on caring for those who fuel the food system. And then I've also recognized Rocky Massey, Chief of Staff, and Danielle Harmon, who is responsible for the community-facing public development and public health community development. So I will pause there.
Thank you, Bree and Mike. I think we might have time for 1 or 2 questions. Does anybody? I don't have any hands up here. We are running a little tight on time, so we can also just keep the conversation going in the Q&A and the chat. We do have one thing that just popped up here. Curious to hear everyone's thoughts on including high quality supplements as part of food health conversation and payer coverage for these. These can aid in improving nutrition as we slowly transition our crops to better growing and processing practices. I don't know if that has any relevancy to what ARH is doing, or if it's just a general comment to the group.
Rhea, take that one if you have any comments. I'm not sure I have a specific depth of knowledge.
No, I don't. Yeah, it's general. That's where the healthcare and the payer side all sit very separate.
Wonderful. Well, thank you very much. I think we're going to turn it over to our next speaker, Dr. Robert Lustig.
Well, thank you, Eva. Appreciate it. Let me go ahead and share my screen. Hold on. Oops. And there we go. All right. So some of you may know me. I am a pediatric neuroendocrinologist, and I've been, involved in the diabetes and obesity wars for many years, both as a physician and now also as a policy wonk and advocate. Want to talk to you today about the problem with nutrition. Every one of us has been given a fiery red brand new Corvette. And our goal is to keep that Corvette from turning into this jalopy here. And the problem is there's no owner's manual and there's no warranty. And the question is, what do you do? Well, that's a big problem. And we have done a very, very poor job of maintaining our fiery red Corvette. And everyone wants to, and no one can. And the reason I think is on this slide, because we have confused and conflated these three terms: food science, nutrition, and metabolic health. Food science is what happens to food between the ground and the mouth. Nutrition is what happens to food between the mouth and the cell. Metabolic health is what happens inside the cell. Unfortunately, it's only what happens inside the cell that leads to disease. Type 2 diabetes, hypertension, dyslipidemia, cardiovascular disease, cancer, dementia. All the reasons for this conference today are all inside the cell diseases, and we are not dealing with it. Nutrition only informs metabolic health, and it is one step divorced from it. Food science informs metabolic health, but it is two steps divorced from it. We actually have to use metabolic health as our North Star, and we have not been doing that. An perfect example of this, something that everyone understands, this. This goes back to the 1920s, where we said, oh, spinach has iron, we need iron, therefore we need spinach. Yeah, well, unfortunately, the iron in spinach is ferric. The absorption is less than 2%, whereas the absorption of ferrous from meat is 13 to 15%. And so there's a perfect example of why metabolic health matters. The absorption matters, the targeting to the cell matters, and ultimately what happens within the cell in terms of mitochondrial metabolism turns out to be perhaps the most important thing. So in my book, Metabolical, I actually talked about the 8 subcellular pathologies that belie the aging process, and that's also the chronic disease process. For those of you who are not physicians, I basically use this car analogy, this fiery red Corvette. The goal is to prevent glycation, which would be like carbon deposits on your intake manifold, oxidative stress, which would be like rusting of both the body and the chassis. Mitochondrial dysfunction would be like a defective transmission. Insulin resistance would be like having a sticky carburetor. Instead of going vroom, vroom, you go put, put. Membrane instability would be like having an oil leak. Inflammation would be like having rotted fuel lines, which can catch fire at any moment. Methylation would be like having defective spark plugs. So instead of driving a V8, you're driving a V2. And finally, autophagy is like oil sludge. The problem is, when you take a look at all of these 8 subcellular pathologies, the thing that causes them are food. None of these are druggable, but they are all foodable. By altering the food. And the problem is that ultra processed food is a disaster in terms of all 8 of these and drive each of these 8. So people say, what about exercise? Well, exercise is the second best thing you can do for yourself, but there are 4 of these subcellular pathologies that are not amenable to exercise. In other words, you cannot outrun a bad diet. Thus, food is medicine and food is health. And unfortunately, as you all know, we are eating an enormous amount of, shall we say, not food. Ultra processed food. And ultra processed food currently is 57% of US consumption and 73% of the US food supply, and has been linked with all of the chronic diseases that I have talked about. The food industry will tell you that processed food has a role in nutritious and sustainable diets. I would tell you that processed food is an experiment that failed. Question is, what do we do about it? So, we've been talking about food as medicine. The problem is food is also poison. And how do you tell which is which? I was very interested in Eric Smith's and also Joseph Pizzorno's talks today, and this will dovetail with both of those very well. I am the co-founder and chief science officer of a nonprofit called Eat Real, and our job is to get real food into K-12. We just had our board meeting yesterday at a school in the Salinas Valley in Morgan Hill. It is the second poorest school district in Northern California. And this is our team. But I want to show you what using Eat Real standards can do for a school. This is the vegetable and fruit bin. This is my lunch yesterday. This is my chef salad, and this is my focaccia pizza with broccoli rabe, along with the carrot sticks. And I will tell you that I would put this up against any restaurant food. Now, the question, of course, is what's the cost of this? The USDA provides $2.86 per person per child for food. This meal on average costs $3.50. So I asked the food services director of the school, how does he make up the difference in terms of the extra 66 cents? And the answer is by local sourcing, he is working with the community, he is able to make that up in spades. And he is actually now able to sell the food from the school to the general community. They actually were able to feed the entire city of Morgan Hill through COVID. The school was, the middle school. This is just crazy. But it's eminently doable if you actually, switch to real food, and we're going to continue to promote that. We are now in 10 states, and the goal is to be in 20 by the end of 2025. So the strategies in terms of improving metabolic health are to promote metabolism, that is, in particular mitochondria, and inhibit inflammation. Now, the question, how do you do that? Well, then you need to know what is healthy. So Michael Pollan famously said, eat food, not too much, mostly plants. There's a problem with all 3 of those clauses. Eat food, well, some people need a low-fat diet, others need a high-fat diet. Not too much doesn't take into account mitochondrial dysfunction, and mostly plants, just remember Coke, Doritos, and Oreos are all vegan. Because it's not what's in the food, it's what's been done to the food and really what the corporations did to the food that matters. And that's not what's listed on the food label. So I actually suggest 3 different principles. And we put together a scientific advisory team to actually help ultra-processed food companies become healthy food companies. And we published this last year in Frontiers in Nutrition. It is called the Metabolic Matrix, and this is completely evidence-based. And basically, it targets 3 organs: protect the liver, feed the gut, support the brain. And here are the basic principles and strategies that one uses to accomplish this. So the question is, can this actually be done? Well, we are actually turning a company in the Middle East around on a dime to turn them from a metabolically unhealthy company to a metabolically healthy company. It is called Kuwaiti Danish Dairy, and we hope that this will actually be a template for other corporations to be able to do the same thing. We're going to be giving a talk on this in Davos next month. The science is very clear. All we need to do are four things: less sugar to protect the liver, more soluble and insoluble fiber to feed the gut, more ALA, EPA, DHA micronutrients to support the brain, and a limitation on emulsifiers to reduce the inflammation. Now, obviously, a real food diet is the best way to do it. The problem is we're not going to have enough land and ocean to be able to feed 10 billion people by the year 2050. Unfortunately, against my, better judgment and my predilections and opinions, processed food is here to stay. And we needed to because, again, we're not going to be able to feed that many people and we can't have a famine. So the question is, can we help the food industry re-engineer its current practices? Can technology help and also help turn a profit? So we have to work on ingredients, we have to work on processing, we have to work on packaging, and lastly, we have to work on data science. And I've been involved in three separate aspects of this. I will talk about very briefly for each of these. So from the ingredient standpoint, KDD, from the fiber standpoint, Biolumin, and also from the data science standpoint, a group called Perfect. So this is the paper that we published last year in Frontiers in Nutrition, working with KDD. And these are the things that we have focused on to actually bring KDD out of the Stone Age and into metabolic healthy food. And we actually have data now to show that the products, 10% of the portfolio of KDD, that's 18 products thus far, have actually been turned around and have data to show that they are now metabolically healthy instead of metabolically harmful. We have focused on sugar reduction, non-nutritive sweeteners, emulsifiers, fats, fiber, dairy-based ingredients, processing, packaging, and food data science, sorry. We sent all of the products, all of the products that KDD made, and also the products that KDD purchased from other vendors to Eurofins for biochemical analysis, because you have to know what's in the food before you even make the food. And so this is an example of what Eurofins was able to do for us. And these are examples, this is just an example of the change in the recipe from their conventional chocolate milk to their real food chocolate milk. And we now, have been able to not just lower calories, but specifically lower sugar and increase omega-3s in order to be able to actually make processed milk and ultra-processed food healthy. We did a full analysis of emulsifiers. The biggest problem in emulsifiers is E471, which you can recognize on the food label as mono and diglycidyl esters. We are also interested in fibers, and there's a lot of people who are very interested in fiber. The problem is that the only way to put fiber into food right now is soluble fiber, which means short fibers for the most part. There are a lot of fibers on the market, but the problem is they do not have insoluble fiber. And when you look at the meta-analysis of dietary fiber intake and all-cause and cause-specific mortality, the insoluble fiber is much more effective than the soluble fiber at 90% to 10% in terms of reducing cardiovascular disease and cancer. The problem is that insoluble fiber is normally not able to be added to food because it's not miscible. So how do you get insoluble fiber into food? So I am a co-founder of a fiber company called Biolumin. It is a microcellulose sponge. It is 7 microns in diameter. It is colorless, odorless, tasteless, textureless, and it absorbs 6 times its weight in carbohydrate, that is glucose, fructose, sucrose, simple starches, rendering them unavailable for early absorption. So you swallow it, it expands in the stomach. That gives you a feeling of fullness. The nooks and the crannies start becoming prevalent, and embedded in those nooks and crannies are a set of proprietary hydrogels, soluble fiber. I would have to, spend 5 hours explaining why we use the different soluble fibers that we use. But ultimately, they feed the microbiome, generate short-chain fatty acids, sequester the carbohydrate that's in the food. So basically 1 gram leads to 6 grams of carbohydrate sequestration. So 1 teaspoon, which is what we recommend with any meal, will actually absorb 25 grams of carbohydrate. We can reduce glucose absorption by 33%, fructose absorption by 36%, sucrose absorption by 38%, simple starches by 9%, increasing the butyrate by 60%. And actually, we actually have 2.5-fold increases in human trials, and with virtually no gas production and no side effects. This is what our glucose response looks like with a candy bar versus a candy bar plus biolumin, a 20-point attenuation, and also notice a quicker return to baseline with no reflex hypoglycemia here, rebound hypoglycemia. And in clinical trials of 3 and 4 weeks, we showed reductions in postprandial glucose excursion, reductions in postprandial insulin excursion, and again, a 2.5-fold increase in butyrate production. In addition, we, similar to what Eric Smith is doing, we are, I'm engaged in a project called PERFACT, where we use the science of metabolic health to actually determine what's in your grocery store and what you should buy based on your biochemical profile. So we can access 80,000 items in the grocery store and determine which products are best for you and best for your family, without having to go into mega detail on specific components. And so this is my final slide, and that is my various websites that you can look at. My basic website, Eat Real, is here, Biolumin here, and Perfect here. And with that, close by saying we have to do public health intervention, which is 1 population at a time. We have to do personal intervention, which is 1 patient at a time. And we also have to do technological innovation, which is 1 company at a time. So with that, I'll close. Thank you.
Thank you, Dr. Lustig. Do we have any questions or comments from the audience here? Go ahead.
So, Dr. Lustig, I just wanted to say thank you. I've been following your work for a very long period of time. And actually, we met at AHM many, many years ago. But I just want to say thank you. Fantastic work.
Thank you. Appreciate it.
Well, thank you very much, Dr. Lustig. I think probably everybody's brains are starting to turn to mush by this point. But it looks like you gave lots of great ways for people to connect with you. And we'll again keep the conversation going, I'm sure, after this session. Next we have up, last but not least, Ellen Brown.
Hello. Do I just share, Ava?
Yeah, go right ahead.
Okay, great. I didn't know if there were any sort of restrictions here.
Don't share too much, Ellen.
You love Carter's
I do.
like,
While you bring that up, I do have one thing back to Bob. One of the challenges as we think about the food system and ultra processed and such is what needs to be in the original crop, nutrition wise, what we should think about sort of fortifying in the system. I mean, there's a certain, to some degree, the form factor of processed food has got a certain advantage and convenience and such. So we sort of think about fortification and then supplementation, which I don't know whether munch is in the supplementation category but
yeah. Well, it can be in the supplementation category, or it can be in as a food additive. Ultimately, there's not that much difference between the two. So if you're doing it D2C, it's supplementation. If you're doing it B2B, it's food additive. But
in the balance of all those 3 mixtures for like the people in the CPG world or the real food world, do you have a sense as to core food, fortification, supplementation as to like on an N of 1 on a human patient level, what matters? Or I don't know, it's a sort of a broad question.
So what I would say is that supplementation only works if you actually absorb it and metabolize it and get it to where it needs to go. Almost all of the supplements that are out there don't do that and have no data to support them. A perfect example of this would be CoQ10. Okay, you can take CoQ10 till the cows come home, and it's not getting to the mitochondria where it needs to go. That's been shown a zillion times this way, 50 ways from Sunday. So just because something's a supplement doesn't mean it's good. The question is, how do you get it to where it needs to go? And does it work once it gets there? And is the system even able to accommodate it? Like, for instance, fructose being a mitochondrial toxin actually destroys AMP kinase. You can't make new mitochondria. So until you get the sugar out of the diet, no supplement to try to improve mitochondrial health will even work. So, so the concept of that's where this difference between metabolic health and nutrition comes in. So nutrition would basically be, adding up a bunch of numbers on a balance sheet and saying, oh yeah, we reach 100% of the USRDA. Bullshit. Garbage. Okay, because it doesn't matter if you reach 100% of the USRDA if it doesn't get into the cells and doesn't do what you want it to do.
Yeah. Very good. Thanks. Ellen?
Well,
Yes.
Dr. Larson, there's one more question I missed. What is the data source, e.g. Food Data Central?
I'm sorry, Food Data Central?
What's the data source? I think it related to Perfect.
Oh, so we used Perfect to analyze the entire US global branded food database. And I have the data, I can show it to you if you want. But we basically demonstrated that, particularly around the concept of sugar, because the global branded food database does not identify all of the things that are sugar. 44% of the global branded food database is wrong.
Got
So
it.
again, you have to know what you're looking for in order to evaluate it. And we've talked with Naomi Fukugawa and her colleagues at CRS, and they know that it's a problem, but they have no money to fix it.
Thank you, Dr. Lustig. All right, Ellen, take it away.
Okay, great. So I'm the caboose on a Friday after we've been sitting here for hours, and I wish I could do some sort of a jig to wake everybody up, but I can't, and nor will I be distributing sugar. So I am going to jump into the most boring presentation of our entire day, which is healthcare. So I am the bookend. Erin was the bookend of food. And I am the bookend of the evil empire. And I am going to jump into a serious slide. And I hope that some of you can understand why I'm doing this. So something really tragic happened on Wednesday. And it was unfathomable. But in my opinion, it is indicative of the tipping point that we are reaching in the healthcare industry. And the reason that I think it is relevant to this conversation is that I think it signals an opportunity for us that we didn't even have a week ago. So, and just follow me for a second. I believe that the death of the CEO of United Healthcare, of the health plan, that is now it's coming out as being a targeted killing. There were words on bullet shells and casings that make it seem that it probably was related to a denial in healthcare. All of this is all very speculative, but assuming it plays out the way that people are saying, I really believe that there's going to be hearings and investigation and discussion around claims denials, claims and billing practices, prior authorization, all these fun things around healthcare. And I actually think that this entire movement that we are also dedicated to around how do we get people healthy again is a counterpoint to debating about how health insurance companies maintain their margins when our healthcare is declining rapidly as a country and as a global economy. So I put this up here because food is health, in my opinion, is the solution. And I think that this sort of sentinel event that's going to prompt a lot of discussion at even a policy level, I think we need to try and push harder and say, it's not just about the administrative piece. It's about addressing the root cause of health. It's about addressing why health insurance companies can't turn the profit that their owners have. And I understand we could debate for-profit capitalism, all of that. The bottom line is, if we were healthier, we wouldn't be having the same discussion. So I put this out there. I may or may not have woken everybody up, but I believe there is an opportunity when we talk about policy that we can be a solution to an industry that really is perceived as corrupt. So jumping into our fun healthcare system, Katie will hopefully like this visual because we drew it at her dining room table a couple of months ago. But this is really the sick care system from a person perspective, and it highlights where we're missing and where we have a lot of breaks in the system. This is Carter's point about the 1.5 trillion and the 1.9 trillion. I've actually updated it to 3 trillion because now we're saying that 90% of our expense, as much as 80-90% of our expense, is now attributed to chronic conditions. So 1.7 trillion spent on this kind of crap is now yielding 3.5 trillion being spent on chronic conditions. It's being funded by employers, health plans, and the government. It's funding a system back and forth here that falls into this, and it's basically a spiral. So you get into this as a person and you get stuck. And so what happens is people go into this vortex, they don't get the answers they want, and they go up here to social media, Dr. Google, friends, and family. And there's no cycle back and forth, and there's access and cost. And so this is the opportunity we have. How do we tap into social media? How do we tap into the internet, electronic means, all of this? How do we create a Google for healthcare, for example? How do we fix access and fix cost in a new healthcare economy, in a new healthcare system that's linked back to food? That this line that we heard so clearly today with Dr. Joe and Dr. Lustig, where there is absolutely no relationship between health and food. We have lost all relationship with that. We have to fix that. We have to bridge that gap. So some of you know I have been really trying to understand lifestyle medicine. And I throw this up here because I'm unlike a lot of folks that are saying we just need to pivot from where we are today and sort of leapfrog all the way out to the future state. I believe there's a middle ground that we can pull some of the 4.5 trillion along with us. Because my worry is if we just jump all the way over to a direct-to-consumer model, we're going to lose all the people that rely on their health insurance to pay for their healthcare expenses. So yes, there are a lot of people that can pay out of pocket, but once you tap out on that audience, you're stuck with a whole majority of a population that have to tap into their health insurance premiums. They do not have any discretionary income to put towards the things that we talk about, the solutions that we talk about. So I firmly believe that we have a massive opportunity when it comes to chronic disease. Every stakeholder in healthcare has the same aligned incentive of reducing the chronic disease burden, period. We don't have to talk about whether or not wellness and prevention matters. We don't have to get into that argument. We're talking about a $3 trillion problem that's driving exponential healthcare expense growth. So how do we change that? So in my opinion, we have food, and food needs to be an integral part of that, but there's still medicine. So how do we take the dollars that are being spent on health insurance today and reallocate a portion of that into a healthcare economy for people that actually want to reverse their disease and they don't want to just treat it? So on the left side, you see our current system of sick care. It's allopathic medicine. I don't need to read all the words here. And on the right side, I'm calling it lifestyle medicine. We could call it integrative. We could call it a million different things. The reason I stick with lifestyle is for the pure simplicity of lifestyle medicine. It's 6 pillars. It's not based on a bunch of technology. It's not based on a level of diagnostics that is questioned from an economic perspective when it comes to healthcare expense, right? A reward piece of that. It's a very simple approach. As I've shared with Carter and some of you, the case for lifestyle medicine is so compelling in the chronic disease front, I can't even tell you. So this page, I hope you guys can take a second and read this. I literally just pulled from the ACLM annual conference, which is the American College of Lifestyle Medicine. And the reason I talk about them just for this group is that we need a bridge for our medical providers. We have all of our MDs and clinicians today. And if we just suddenly go over here and say, well, this other person is now going to start fixing things for people, right? Like my dream of farmers, like with Aaron, farmers can't be recognized by an insurance company as a clinician. We need a piece to bridge this where we have a clinician that's recognized as a medical professional. And lifestyle medicine board certification fits that niche perfectly. Because when you layer it on and you teach people, you teach clinicians how to actually modify behavior and how to support people change their lifestyle, everything switches. So if you read this, I sat in Orlando and talked to 35 different people. We recorded 35 different podcast episodes, mini episodes, and 20 of them were clinicians. And if I can tell you the success that they yield from literally counseling in a group session patients over 8 weeks about how to change behaviors and how to eat healthy, they don't even have to provide the food. They just have to teach people how to do it, how to change their lifestyle, how to modify. The results are profound. So I really think that we have what we need to do this. And so we have two options. We can continue down the sick care train path, right? Where we're relying on silver bullets like here on the left. We're already handing, I mean, Carter and I bantered about this the other day. Carter, what did we say? It was 300 billion, 200 billion on GLP-1s.
Yeah, we calculated it that if you applied GLP-1s to the sickest 20 million people, that the net effect on healthcare revenue, not the reimbursement side of it, the revenue for the hospital system would decline on the order of $300 billion, which we have seen at the major healthcare centers that their people have done some analysis around this and sort of shocked and realized that the GLP-1s may dramatically near term reduce their revenue in an unexpected way, which that's not an advocacy of GLP-1s. It's just that major centers may have a revenue impact that scares them because they're in the business of treating the sickest people.
Exactly. So instead, if we use GLP-1s with food, we really look at creating a sustainable model. So fine, if somebody has coverage for a GLP-1, use it. If it's a silver bullet for 4 weeks and it gets them to where they can suddenly just immediately switch a dime just to be able to kickstart things. But let's not stop there. All the things that we talked about today with food and nutrition, that's what we have to incorporate into the healthcare model. And then if you layer lifestyle on top of that, you really do have the perfect solution without having to go out and create some fancy tech tool, embed some fancy AI. It's really brass tacks. It's the way healthcare was meant to be delivered. But the key here is linking the food and the health. Okay. So what does that look like? This to me is the really important piece. And this is where I drive everybody crazy. We have the 3 trillion that I talked about on the one slide in the center, right? Everybody, every stakeholder in this agrees that 4.5 trillion isn't sustainable, not when it's going up at the rate that it is on the healthcare side. Everybody agrees that the sick care system is a sick care system, but what we don't have is a way to reverse lifestyle disease, cardiometabolic disease, $3 trillion in costs. And why? Because of the incentive that is created on the sick care system, right? So in my opinion, instead of trying to fix that, we need to create an alternative, an alternative, call it a risk-bearing entity, but basically harness that money. So create a vehicle to say, look, fine, we'll take the financial risk. We'll deliver the care in a way that's going to actually allow the people that want to engage in reversing their lifestyle disease to reverse their lifestyle disease. Okay? If you took the 3 trillion and you took 30% out of it, which if you look at some of the actuarial data that's out there, it's up to 70% that comes out whenever people reverse these conditions. I'm not exaggerating here. So let's just assume 30%. You're talking about a $900 billion opportunity. If you split that savings the way most value-based incentives are split today, 50-50, you're going to have 900 billion that's going to go to the risk-bearing entities, and then 450 billion of that can be passed down to what we consider health. That can be funding the things that we're talking about. But what the key is that we have to be able to step up to the plate to take the financial risk. We have to be able to put a model together that says, I'm accountable. I'm going to deliver the value. I have a care model to do it. I've put the pieces together for you. And it includes the things that we just talked about. And then we get the money. And I think there's a golden opportunity for us as a collective group here to be able to do that. And so at the end of the day, there's a big question, right? This is what I was sort of alluding to, is this is where we are today. We have comprehensive insurance. I think that's one of the biggest pain points that we have today, is that most Americans, the majority of Americans, their entire healthcare budget is being invested and chosen and selected on their behalf by either the government or by their employer. Even if they're picking it themselves, it's the government that's choosing it, because the government is choosing the benefits, not the person. So imagine if you could break insurance apart, which I think we are going to ultimately have to do, and create a catastrophic plan and then create a supplemental plan, and allow people to choose what that supplemental plan looks like. Allow them to say, I want a certain portion of my insurance premium to go towards healthy, nutritionally dense, chemical-free food. I want a certain portion of my money, or I want a discount at the grocery store as a result of that, and I want to go to this particular grocery store that's been redesigned because now there's a demand. Or I want to be able to tap into the regenerative farmers that come with a relationship with this plan that's being offered, right? If you start to break that apart, you move into a different healthcare 1.0 from where we are today. You actually create healthcare, a place where people can get healthy and stay healthy. Because I argue that today we have sick care and we don't have that. So in the middle, the employer still chooses the catastrophic plan, let's call it, but the employee gets to actually start to have some ownership in part of how their insurance premium gets invested. Food becomes integral. We've been taught, Aaron and I talk about doing a food-based ACO, accountable care organization. We're like, why not? Why can't we do that, right? Having a risk-bearing disease reversal care model, not a chronic care management model, not the same crap that we've seen a million times over, but it's value-based, it delivers true and outcomes. And then we get to N of one healthcare, which is what I think Dr. Lustig and Dr. Pisano does such a beautiful job of showing, is that we are all individuals. We all have to have N of one healthcare. But I just think it's going to be extraordinarily difficult to take the masses and give them what they deserve if we don't do something in the middle with the $3 trillion being spent on chronic care. So therefore, I'm the economics geek in the room. I'm all about trying to create sustainable models. So that's why Aaron talked about the fact that our firm worked with her to work with insurance company to make sure that it's an outcomes-based model, that she's getting incentivized for the improvements in the healthcare that's being delivered through the food that she's providing to these patients. And we're trying to work with lifestyle medicine to say, how do we make that into, that to me is the real solution for chronic care management. That's how you actually deliver value. But it's creating those risk relationships to be able to redistribute the dollars. So anyways, there you go. Happy Friday.
Thank you, Ellen. Nathan has his hand up. Go right ahead.
Hi, Ellen. That was an inspiring presentation. I'm curious, do you have a vision for how to transition all the dollars being poured into healthcare now to a more preventative model? And I'm particularly interested in HSAs. I know it's a short-term solution and kind of a symptom of our existing system where everything flows through insurers, but like there there is currently $120 billion sitting in HSA accounts. So curious, like what you think of HSAs, and then long term, like how do we get the money being spent on health insurance premiums today into like medicine?
So I think it's twofold. I think I agree with you. I think it's unlocking the discretionary income. So there is going to be some policy needed with the HSA dollars to be able to free it up for democratization, for people to be able to do more with it than they do now. So I think when we dive deep into policy, that's some of the nuances in policy that will be needed. I think on the insurance side of it, the employers are key to that. So I think if you can get a couple of really large employers to get behind a concept like this of I'm going to offer another type of health plan. So my vision would be that there's a couple of different entree points, but I guess I would go back up to saying always go back to who holds the insurance risk, who's ultimately responsible for the insurance risk of the person. And then follow the dollars down, because it's a lot more complicated, right? Like you could say Humana is the insurance company. When you actually follow the dollars down, a lot of times it's the provider that's responsible. They're the ones that are holding the financial risk. And so I think the important piece to answer your question is, one, you can start on an employer side and they're holding their own insurance risk, right? So you have a big entity that you can go after and you can say, hey, let's do something really interesting here. And let's have the regular health plan that most people are used to enrolling in, but let's create another health plan. Let's create another benefit package that puts all of these things together that we've never considered part of health benefits. Let's make that the benefit plan. And let's allow your employees to choose and say, hey, I'm going to go, I want to keep getting pills, or, hey, I want to go over here and I want to actually focus on my health. And the important thing is that you really, sadly, economically, we're going to have to focus on including enough of those chronic disease management folks or the chronic condition folks in order to have a risk pool that's going to offset, because it's the savings on those people that are going to have to be reinvested back in. If all we do is take all the healthy people and start offering more services, then we're never going to win. And that's where we've gotten stuck in the past. And that's why I keep going back to this middle ground, right? It's this Venn diagram of there's this middle ground that everybody agrees on, which is the chronic disease. And that's a place where there's so much that we can take out to be redistributed. So, and then the other place, Nathan, I also think there's a big opportunities is organizations, some of those downstream risk-bearing entities like accountable care organizations that can also be part of this equation. So it's too many things to do on a Friday when we're already out of time. But yes, good question.
Something sort of a twist to add on to this conversation that's been going on with Aaron, me, Ellen, and others a bit is we said earlier there's a proving ground in rural to fix food and health. There's also a proving ground, I think, around call it the 20 million sickest people. And there are opportunities for, if there is a patient in those 20 million that is going to be responsive to a food program and they're coming with $30,000 of ACO dollars and you can treat them and secure them for 5,000, there's a very dramatic economic incentive from the health insurance ACO to deal with that. At the same time, the sort of standard of care for lifestyle medicine is not really comprehended by CMS well. And the person who defines those new approaches is going to have an advantage. And when you look at Hims and Hers, as much as we think of them as a boner pill company or something like that, they're a lot like Amazon Books was. There's a disruption in which the consumer, the standard of care, Rob and Dr. Joe have defined the standard of care very effectively in many cases, but very few in the healthcare profession are actually delivering it. You start to get into a mode where something like a Hims and Hers actually can say the consumer is expecting an iPhone experience and a different kind of care experience. And while they may be short on terms of the deep healthcare side of it, on the front side of being able to organize the patient around the fact that the patient can't even access the standard of care, and now maybe they can get 50% of it, where when they go to PCP, they get 1% of it. There's an opportunity for a shift to go on there, and if that shift occurs, I think we're going to see another way for healthcare to deliver it. And then if healthcare's ship is on fire with the GLP-1 near-term impact, we may not want GLPs long-term, but if they all of a sudden start seeing major revenue concerns coming in, and Ellen, to your point of the recent event, we know that Marshall and Bernie are like ready to blow up the PBMs, and really during this period of time, but if you blow up the PBMs, UHC has got zero profitability at that point. And that is on the agenda to blow up the PCPs. Dr. Joe, I'm sorry, I sort of overwrote you, but I think you got your hand up.
Oh, no, that's great. So Ellen, fantastic presentation. So a comment and two questions. First off, comment. I would suggest relabeling this disease medicine and health medicine. And I've written an editorial in PubMed on health medicine, which lays that out. And I'd love for you to take a look at it and see if you'd like to do an updated co-editorial with me on changing this. Very interesting.
You're getting real-time update on the spreadsheet.
Yeah, that's incredible.
I mean, I'm the author of it. I can do what I please.
Yes. Okay. And now the second thing, so when I started to get my AI to work and improve people's health, I went to the medical director of a local major healthcare company. And I went to him in particular because I knew this medical doctor was sending his children to one of my naturopathic graduates. Okay, so I knew he was receptive. So I went and showed him what we were doing. He said, "Oh God, this is great, Joe." He said, "But you don't understand." I said, "I don't understand what?" He said, by state law, we only are allowed to make 7% profit. So the only way for us to make more profit is for healthcare to become more expensive. We have no incentive whatsoever. As a matter of fact, we have disincentives to make healthcare less expensive. So all the things you're talking about, I didn't hear you talk about that, but I think that's one of the one of the big elephants.
So I have to push back. Not push back. I hear that regularly, and I guess what I would say to the person that you're citing is that for us to be able to get a medical, like if you think about, we spend somebody pays $1,000 to cover their healthcare expenses, right? Right now, on average, health plans are at best spending $850 of that. So let's say it's $1,000 that someone's paying in. Health plans are generally, for healthcare costs alone, are spending $850. And then they have another, let's call it $100 in administrative expenses, and then $50 left at the end of the day. Okay. I would argue that it would take so much momentum for us, so that's an 85% ratio, right? It's the cost of care is 85% of the amount of money being paid. The laws that you're talking about is that you're not really supposed to go like 78%, below like 78% or 80%. For us to swing a whole 7% on premium for an aggregate health plan would take such a shift, like a paradigm shift, that I think it would, I honestly don't even know if it would be possible that you could do that.
It did happen during COVID, right?
Well, yes, but that's like,
but that's an example of the shock that.
Correct. But I think you could get ahead on policy, Joe. Like I think you could be ahead of the curve on policy, that if you're like, hey, we're gonna do this, that, and you know what I'm saying, that you could then you would be ready to work with the policymakers to say, look, this is what we're doing, and having a minimum medical loss ratio. Plus, the other thing is you just have to reinvest it back in care. You could still have a 60% medical loss ratio all you want. There's plenty of health plans that have a good year. They have to reinvest the dollars back into their primary care physicians. They have to incentivize those people that are delivering the care back into the hospitals, back into care delivery, or the benefits for people. Guess what? You give people more food. You'd be totally allowed to do that. You could say, hey, the benefit this year, because you guys got healthier, is that we're going to actually give you all $100 of food a month. So, I mean, that's the thing, like you are right. But on the other hand, there's a whole nuance to that could really be used to the advantage of a model like this.
So part of the reason for anybody, I've found that Ellen is really leaning forward in a lot of this thinking. She and Aaron put together. Can we mention that program with Aaron? Is Aaron
Yeah,
still
Aaron mentioned it. I mean, I don't say the name, but
So they've got an incentive-based program in which, meaning they're doing food as health, food as medicine, and if they hit certain A1C and BMI targets, they get Aaron's program gets extra benefit, economic benefit.
yep.
The other thing that we've seen in that is there are a few, you've got guarantee issue under the ACOs. We're seeing a little bit of signal from some of the ACOs that they would like to use somebody like Aaron's program as a customer acquisition, so that if if you have a program that's doing food as health that's going after the sickest patients and those patients are willing to adopt it under that kind of program, there's a certain decision point on the ACO that they want to go target those people and bring them in to their ACO because they come with whatever $30,000 with them because of their conditions. And if they're going to be responsive to food as health. So what we might start seeing, and this is an opportunity for everybody who's out there as an entrepreneur, is your ability to positively selection bias of the worst patients, which ones are more willing to be responsive to a food as medicine, a food as health type program as opposed to put me on GLP-1. That all of a sudden is a different landscape that starts to put some energy into entrepreneurs who might be able to start shifting the industry off into a different direction. I think, Dr. Joe, what you're working on, and Eva, we're not presenting Alden.
Not to sign. They'd like to present next time. They
Okay. So we're starting to see some N of one tools come down the AI path. Dr. Joe's company is sort of a leader in this area. There are a couple another company, Alden, that we're working with is doing this from a proteomics standpoint, but the framework ability to sort of push an N of one standard of care out to patients willing to sort of be early adopters with some of the AI models and care models that are more digitally based are also going to reflect the patients most willing to adopt. And as we think about policy, we would love to solve it for 320 million Americans. We need to really track down the early adopters who are in the lifestyle medicine camp and expand that.
Which is why, Carter, I always say that I think that this is actually an imperative, this middle ground of healthcare, this disease reversal is an imperative bridge to be able to get this N of one to the critical mass. Because if we can unlock if we can unlock the 3 trillion in that middle ground, then you can move it over to N of one. And I think it's going to be simpler than trying to leapfrog all the way over.
Yeah. And I'm not positive which of it is, but I think one of the things that if I were in a policy room with somebody in DC, I'd like to figure out, I think, it's just me as a lessons in innovation, is I'd like to find who the early adopters are and then test it out there. Because we put these giant policies in place and say, day one, it's going to solve it for 320 million people. And it's just not so. But a concept we're thinking of pulling together here is something we call proving grounds, in which we take some of the comments that everybody has made here and say, hey, here's a rural setting in which, like at AHR, we've got a test bed where we can integrate these things within a fairly controlled environment, but AHR is still a 400,000 patient system. Let's work there first, or let's go after the 20 million sickest that maybe are GLP-1 patients that we can like migrate over, or there are these different clumps that we're thinking about that maybe we should be advocating a sort of a proving ground concept to as a first build of better health.
But Carter, I was mentioning in the chat, I would love to see some more predictive analytics to get us to some real tipping points that we can agree on, right? It'd be great to know what are the tipping point shifts that we need. And until we really know that, we're just speaking, it just feels like it's more hypothetical than real. And I feel like we need some real models to build some predictive spaces where these tipping points could really show revenue shifts and business model shifts.
Yeah, and it's an ambiguous thing, so maybe all at the same time. I think Dr. Joe's work initially with his app has done a lot to. I would say that there are, in the first instance, getting people the standard of care. It's dramatic how many doctors, Bob can probably tell this better. How many frontline PCPs still don't get that you can essentially cure type 2 diabetes. Rob, I don't know if you'll let me say cure, but pretty goddamn close to cure. Oh, I dropped. We lost him just at the wrong time.
Yeah.
We're at the top of the hour. I apologize, and I've been on transmit a little bit. Jim, is your question quick or?
Yeah,
And then,
it's
Joe, do you
pretty
still
quick.
have a question?
Yeah, I do have a question. And it's really kind of advancing this to the policy side. So there is an example. One comment, real quick, is there's a really good example of some of this succeeding heavily here. And that's Verda. Verda's been doing this for 10 years. They're doubling their business every year. They're worth over 2 billion. They'll have their IPO in the next quarter, I believe. But they're doing a phenomenal job, and all of their work is at risk in the employer space. And they are a provider, so they can't drop into an FQHC. They can't drop into a health system, but they're a good model to look at, and they've got great ROI data if anybody wants to look at that. So my question is this, kind of to Ellen, because Ellen knows more about the payer space than anybody that I know, is, today at Becker's did a great article out on the specific things that have been mentioned by the new administration, but there's not a connection that I see. And what was mentioned was regenerative farming, it was chronic condition management, all the stuff that we've been seeing. How can we bridge as a group, or maybe it's just in more theory, is how do you bridge to what's going to happen in 2 months or 3 months or 4 months and align to that? We know that stuff is going to happen, but is there someone that's bringing this down and saying, this is what's going to happen with Medicaid cuts, this is what's going to happen in Medicare Advantage expansion? Is anybody tracking that and connecting this group to that in some type of model? I would love to see that. Maybe that's a follow-up type of thing.
Yeah, I think that's Jim. I agree with you. I actually think I mean, that's something I have to start doing even for our clients. So, like I have a meeting next week with a FQHC that is very hot on, what the new administration means from a policy perspective specific to them, which is very much Medicaid driven and Medicare driven. And I think I go to also adding that we need to identify these key pain points where it's like, if you could just do this little jigger here, and you could do this little jigger here, and this little jigger here from a policy perspective, like we talked about HSAs, right? Like, if you just put this combination of these 5 or 6 things, right? It's like looking at it at a more global level within policy as opposed to just this one program, right? So instead of saying, well, on the ACO side, I need this one thing changed, to pull up and say, if I'm trying to reverse chronic disease, what are the things that have to happen? And I believe that's what we're trying to do here, right? Is to have that list to say, on the food side, this has to happen. On the healthcare side, this has to happen. First of all, we shouldn't even have sides, right? And if these things come into place, now we can shift over. So, I mean, I think it's something that everyone's planning on doing, Jim, and I agree with you. It's imperative.
I would also say I have had some inbound requests from people I know in policy making positions in the Senate and going on to Department ofs. And I would say if you sort of correct for a certain amount on the lobbying side is like, okay, we got to do this, or I mean, they've got their momentum. Don't let them screw with fructose. Put that side aside. I think that there's an intrigue by some of the policymakers to sort of say, look, we know we're gonna get that hitting us, and we're gonna have to be responsive for it, but we need more insight. And part of the reason that we started generating this is I was getting those requests like, we need some more internal insight into what's really going on, because we're really not that smart on these topics. And really, the network we've got here, both on the WhatsApp group and such, I think represents a reasonable set of knowledge. None of us should expect like, oh, okay, this guy go over there and they're going to make a decision, and then Shazam, we're going to go in with a bill. I think it's much more nudges along the way to remove the friction so that our entrepreneurs can move the ball forward, and really create the evidence that proves the opportunity to make a 50% improvement or a 20% improvement or a 10% improvement, any one of which we should be happy to get. And it's
Agreed. And right now that data, unfortunately, that data is like literally I had to have somebody help me go through research papers one by one, like research posters is like what that data is from, like because there is no massive clinical trial on how to do this, right? Like there is no actuarial study. And so this is all brand new. This is what we're here to create.
And when I did the testimony on the Hill in April, I sort of said, you know, we did a human genome project. We don't have a human nutrition project. We don't have a human microbiome project. We don't have a human soil microbiome project. Those are all longitudinal. Those I would say are all projects that have an equivalent complexity to what we did when we did the human genome project. And so there are some opportunities at NIH level maybe to do that kind of work, but nobody's picking that up. That's not like there's nobody at NIH basically saying, you know what, there is. NIH, we've got people sort of saying, we really need a longitudinal study, but then also the problem with population health is that I think that Dr. Joe and both Bob have said, you know, N of one, your care is N of one. Assuming Eva, we got no other questions.
There have been several questions throughout the session about the follow-up from here. I will say that we will send out the recording to everybody that's registered and make that available. Carter, do you have any comments specifically on follow-up or where we go from here with the policy discussion?
Yeah, it is hard. We are doing a couple things. One is we have a Substack, Food is Health, that I think we shared, and we will reshare, and we will share some of this content out. Ellen, me, and Katie do a podcast that we're going to try to suck some of this into. We are working with a team to maybe create foodishealth.ai that would be a center point where any policymaker or investors trying to understand the space could come and it would say, here are the major policy issues that we've identified related to this, and here's the link over to the domain experts that know something about it. So we're trying to make a digital version of what whenever you go through these transitions or policy papers, we're thinking of taking that a step further, putting a chat bot up with a digital tool set that makes it more real and live for people to do it. That may require some resources, so if people want to help chip on that, we may actually need to put some money together to help dev team do that. Those are things we're thinking about, but really we had a good, 80, 90 people on this call. It's really irrelevant what we think if we're trying to remove the friction in the system. So for everybody who's listened to this, if, let's get some email back on what you think and say it on the WhatsApp group. Is there anything else here on the call that anybody can think of that would make it easier to consume this and remove the friction in the process of informing? Two people we got to inform: the policymakers and the investors. There's nobody on Wall Street thinking about this, not really. And the reality is it will take capital to get some of these changes made. There are people thinking, should they be shorting CPGs? Should they be shorting healthcare companies? But capital is going to be required to make the shift, and so both crowds need to be educated. And there's nobody on Wall Street that gets this. Nobody.
Nope.
But that capital's got to come into the equation if we're going to make a shift. They'll see it. Ellen has started to raise the issue just on the implications of GLP-1s, and people are starting to go look at their patient systems and realizing, oh shit, our billables are going down on these people taking GLP-1s. We hadn't looked at that. That's a wake up moment for them that I don't know what they're gonna do. They're either gonna go buy technology or they're gonna go into
if they feel like they can have a seat at the table around getting part of the savings that they're yielding on the premium side back, then they'll step up to the plate with value-based care.
Yeah.
And that's because that's been the biggest barrier to that so far has been there hasn't been a viable path of healthcare delivery that could truly reduce the cost.
Yeah,
And
and GLP-1s at that point just may be a transition.
I think that's what they are.
They triggered a perspective and then it sort of works out
Exactly.
that like we can do this with fiber and maybe
Yeah, but we need all the food. We need the CPGs and we need we need the chemical free, nutritionally dense produce and then the health care, like Dr.
well, and
Pagano.
if we think about that, this is the conversation when we were at Katie's event. Some of the CPGs turned to me and said, "So what do we need to do to accelerate this?" And 99% of the CPGs I talk to are like, "This is not really happening."
Yeah.
But the answer is, I don't think the CPGs can respond quick enough, and real food will. But then you go back to Walt's area that he's getting backed into a corner on fresh veg, because his economics are working against him, and he's losing. So we like at one point more people will be going to fresh veg. It should be their day in the livestock and meat and real foods day. CPGs are going to have a very hard time responding because they've got to change how they do product development and sourcing. There are amazing frictions in there that for the entrepreneurs out there, there's a huge opportunity to innovate the things that remove those frictions so that Nestle can find the farmer who's got wheat with more fiber. He can't do that right now.
Yep.
So there are those kind of innovations in the background.
Well,
But
and you
please,
could get another food. I mean, I'll say one last thing to that though, Carter. You take somebody like, you look on the food side and you look at a comparable person to like a Hims and a Hers or like a Wegovy or any of those, they could do the same damn thing and create a closed loop system and do this themselves.
Novo could step out and with a partnership with Costco and say,
exactly,
we're going to make what do they call it at Costco? What's their food brand? Kirkland. We're going to make Kirkland a real food,
yep,
keto-esque brand. And for those people at the extreme, we'll deliver you GLP-1s, but we'll also give you a user experience through Costco, Hims, Hers, and Novo.
And they'll partner with a virtual health provider and healthcare will be irrelevant.
Boom.
So anyways.
On that, let's all go eat lunch and go into our weekend and enjoy it. Thank you, Carter.
Very good.
So much.
Thank you, everybody.
Thanks, Carter.
So much.
Bye.
Good conversation. Thanks all.